Whatever.
So can we start?
Whatever, every night.
You are live now.
Yeah, so good morning, everyone. Welcome you all to the WS competitive session for postgraduates on this clinical case presentation. So very happy Sunday to all of you. I welcome on the outset Dr. Aarti Nangia. She'll be joining us a little later because she's traveling. I welcome all the HODs of all the postgraduate teaching institutes who have actually enabled this program to happen. Welcome all the postgraduates and the mentors and the moderators, and a big thank you to the entire team of the WS Odisha State Chapter. So I hand over the session to Dr. Sujata. So we'll be having 3 competitive sessions, and each session will have 3 judges, and the judges will have a separate marking list. The moderator will introduce you to the judges and tell you the details about the, in short, about the rules of the competition.
Thanks, Devi, for inviting me. Good morning, everybody, and all the best to the presenter. So, can you see the slide?
Yes, yes.
Okay. I'm happy to invite the 3 judges and introduce them. The first is Purvasa. She's very active in cornea practice. Recently, I knew that she has moved to AIMS Nagpur. She's associate professor in AIMS Nagpur. And before that, she was working in LJI Institute Ambala. And she's a passionate teacher and was invited to many meetings as a guest faculty. And she's also invited faculty for Cornea Society of India and lamellar keratoplasty limbal stem cell conferences. And she has many publications in various index journals. Recently, she received WS Inspiration Award in the field of cornea. Our second judge is for the session is Dr. Purvi Bhagat. She is from professor in Glaucoma from Ahmedabad. She has 70 publications and more than 160 presentations. She is also very active in WS forum. And she got many awards like Outstanding Work as a Woman in 2000, Role Model of the Year, and Ecoin Gold Plaque, Leadership Award, and again Inspiration Award in 2001. Welcome, Dr. Bhagat. And last but not least is our Dr. Professor Anita Panda, who belongs to Odisha. And all of us, I think she does not need any introduction, but for the sake of introduction, I'm introducing. She was ex-professor and head of cornea services at RP Center AIMS, and she was former president of AIOS, and she is member of many national, international professional body, and she has taught for many years undergraduate, postgraduates. She has more than 250 publication, both national and international journal, more than 100 chapter in book, 10 books. And she was active in banking movement when IVI started. Like a lot of awards. One slide is full of awards, but you can see all the Orishan awards. She's fellow of National Academy, RP Thanda Award. So life achievement for the last one is recently this AIOC. She's getting life achievement award from AIOC, which is highest award in from AIOS. So welcome all the judges and the participant. Rules for the presentation is the presentation for the presenter will be for 4 minutes, followed by discussion by the judges for 4 minutes. But please don't cross the time, otherwise you'll get a -1 mark. So the evaluation is from 40 marks, although it is divided into 4 segments. Presentation is 10, establishment of clinical diagnosis is 10, and management 10, and recent advances 10. And mostly the presenter has to respond to the judges, but in case is required, then moderator, the mentor can chip in. But the primarily the responsibility is Debbie, anything you want to add, or if I forgot anything?
I think the first participant can start screen sharing, which is Dr. Garima. Then as she's talking, Dr. Sabba and Dr. Lakshmi Priya can also get ready, just in case there's some technical snack, the second PG can take over.
I hope Professor Panda has joined, Anita Panda.
Yes, she's there. She's there.
Okay.
Madam?
So this is, I think, last virtual meet before we meet physically in AIOS, most of the people. But I
Madam was there. I think she's not there anymore. She's losing her network, I think, connectivity. Yeah, she's losing her connectivity.
Evaluate.
Okay, whoever is the judges can score, no problem. Since this is an average, so it is okay. We can have 2 judges scoring, and whenever she comes in, it will be 3 judges scoring. It's okay.
Yes. Please stick to time. All the best. So first, the second person, be ready with your presentation. Once the we know, you hope you all of you know the sequence. Is the second one is Dr. Sabha Pareen. Okay, Garima, you can go ahead.
Very good morning, ma'am. Am I audible?
Yes.
Okay, ma'am. Ma'am, shall I start?
Yes.
Please go ahead. Go ahead.
Okay. Very good morning to one and all. So to start the session with, I'll be discussing the clinical case presentation and my guide, Dr. Devi Aishwarya Das, ma'am. So I examined the patient, 20-year-old female. She was married and was housewife by profession. She presented to the OPD with the chief complaints of itching, foreign body sensation in both the eyes, and diminution of vision in the left eye, since more in the left eye as compared to the right eye. These all complaints were also associated with headaches since past 3 months. Coming to the history of presenting illness, the patient was all right 3 months ago, after which she developed the symptoms of itching, foreign body sensation, and diminution of vision. And for these symptoms, she consulted locally, where she was prescribed some medications, after which there was relief of symptoms, which was mostly itching. And there was no significant past history. The patient is non-diabetic, non-hypertensive, and there is no any history of trauma to the eye. Coming to the ocular examination, starting with vision, the distance vision, the uncorrected visual acuity in the right eye was 6/12, which is getting corrected to 6/6 with a correction of -1 dioptric spherical and -0.50 dioptric cylindrical at 10 degrees. In the retinoscopy, normal, it was the red glow was seen. Coming to the left eye, the uncorrected visual acuity was 1/60, and the best corrected also 1/60 with pinhole. It was not improving, remaining to 1/60. In retinoscopy, I could see scissoring reflex. Near vision, in right eye it was N6, in left eye it was N36. Coming to the color vision, in right eye it was 17. She was able to read 17 plates out of 17 plates, while in left eye she was unable to appreciate the while performing the color vision with Ishara chart. Coming to adnexal examination, it was within normal limits in right eye. Conjunctiva, there were tarsal papillae in the cornea in right eye. It was normal in shape, normal in size, but there were few prominent corneal nerves, and there was presence of incomplete pressure rate. Rest of the anterior segment was normal in right eye. Coming to the left eye, the adnexa was within normal limits. In conjunctiva, again, tarsal papillae was seen. Cornea, there was thinning and forward bowing of the slit beam in the central and inferior aspect, with apical scarring with some vertical striae in the central part of the cornea can be seen. In other rest of the anterior segment was within normal limit. Posterior segment in both the right and left eye was within normal limit. So these were the findings on torchlight examination. Externally, Munson sign was positive in left eye. And in slit lamp examination, there was thinning and forward bowing of the slit beam of the cornea, central cornea, with mild apical scarring. So summarizing my case, it was a case of 20-year-old female presenting with chief complaints of itching and gradual diminution of vision since 2 years, with increase in intensity of itching and gross diminution of vision since past 3 months, with uncorrected visual acuity of 6/12 in right eye, getting corrected to 6x with -1 dioptric spherical and -0.5 dioptric cylindrical at 10 degree, and uncorrected and best corrected visual acuity of left eye was 1/60 with presence of tarsal papillae in both the eyes, with incomplete flesher ring, prominent corneal nerves in right eye, and incomplete flesher ring and thinning and ectasia of the central cornea, with apical scarring with underlying striae at the level of desmids in left eye. So my differential diagnosis can be status, it might be status post-trauma, or it can be Tyrian marginal degeneration, can be pellicidal marginal degeneration, can be keratoconus or keratoglobus. So provisional diagnosis, my provisional diagnosis is, it was a case of keratoconus in both eyes, more in left eyes compared to right eye, possibly left eye status post eye drops. Thank you.
Ma'am, any questions from judges?
I had a couple of questions, Garima.
Yes, ma'am.
Yeah, in the history, why did you ask only for diabetes and hypertension?
Ma'am, it's routinely usually asked about diabetes and hypertension, but also in case of diabetic, there is less chances of keratoconus. It's been seen there are less chances of keratoconus because of increased glycation in the cornea, and thereby the stroma is quite strengthened as compared to the other rest of the population.
Just for the sake of all students, I would like to mention that when you are taking your history, it has to be all the systemic diseases, not only diabetes and hypertension. And second is, when you're taking your history, you don't know even your probable diagnosis, right? So you don't go retrograde, that you first see the diagnosis and then take your history accordingly. There will be certain additional points that you do take, but when you're primarily describing your history, it has to be about all the systemic diseases, if at all. Then second thing, you mentioned keratoconus about the right eye also. So what makes you say that the patient has right eye keratoconus also?
Ma'am, there was incomplete flesher ring which was seen in the inferior aspect of the cornea. So, and it was well established in the left eye. So I suspect it was both eye keratoconus, more in the left eye compared to the right.
Anything else you think you're missing out in the diagnosis? Is it only keratoconus or something else which is also associated? The patient's primary complaint?
She was, ma'am, she primarily complained of itching, burning sensation, and diminution of vision, ma'am. So,
so what about the papillae and the itching? Does that add something to the diagnosis?
Yes, ma'am. The regular itching and papillae do have an effect on the astigmatic power of the cornea, ma'am. So that's why in case of keratoconus, we try to treat the, initially we try to treat the conjunctivitis, allergic conjunctivitis part first, so that at least we can reduce that part.
Sorry for interrupting because of constraints of time. So in the diagnosis, you need to add the allergic conjunctivitis also. Right? So that is the associated and primary condition. And just to mention, when you describe headache, you have to mention all the characteristics of headache also when you're describing the complaints, right? All the characteristics and precipitating relieving factors, all that should also be described. Yeah, Purvasha.
So, Garima, that was a beautifully described case, and well done. In history, when you've taken the history of allergies, what more would you like to ask? One you asked, she's had a habit of rubbing the eyes.
Yes, ma'am. Yes.
So, what more would you like to prod in? What is the type of lifestyle that she has, or what is the kind of type of rubbing that she does? Is that important, and do you think it is important for the further management?
Yes, ma'am. Yes, ma'am. Because she's being a housewife, so she'll be involved in a lot of household work, dusting and cleaning, which might precipitate her allergic conjunctivitis. So yes, ma'am, lifestyle modification do play a role in such cases. And Yes, ma'am, that's
The type of rubbing, you should always ask the patient to show how they rub the eye and what
Okay.
is the type of pressure that they're applying on the eye and which eye
Okay.
rub are they trying to rub more. This is one thing. Another thing is
Okay.
whenever you're trying to take history, you should always ask what is their sleeping position. If you can just find
Okay.
out, so that helps,
ma'am.
because if they have, most of them who are having ectatic diseases, it's been found that they have more of predisposition to sleeping prone, that is on their tummies.
Prone.
Sometimes they sleep
Okay,
with their head against their elbows or their elbows against their heads, like that. So that creates a
Okay, ma'am.
pressure on the eye. And that has
Okay,
been
ma'am.
now studied as one of the major predisposing factors for ectasias. So always make
Okay.
sure that you find that out, and you always try and counsel the patient when you're given the diagnosis and trying to understand the further management. You're supposed to
Okay, ma'am.
explain to them that these are not to be done. And housewives
Okay.
don't always cook these days. They also are on mobiles
Yes, ma'am.
and watching soaps
Yes,
and all
ma'am.
that. So they also are prone to visual display unit, computer vision syndromes and dry eye
Okay.
diseases. So you
Yes,
don't
ma'am.
categorize them or generalize them.
No, ma'am, no.
In a
it's
WAS
not like-
session.
Sorry, ma'am.
Puri ma'am, anything else you want to
Yeah. Anything?
We have time, Dr. Aishwarya?
I think we just had 4 minutes completed. We can,
Okay.
one more question, we can go to the second presenter, Dr. Sarah.
Thank you so much, ma'am.
Dr. Sabha, can you share your slide? Is it there? I don't see name. Is it there?
She's there. She's there.
Visible.
Yes.
Good morning, everyone.
We can't see your slides. Please go to the share button in your screen. I'm not able to see at all. You can see your name.
Sure, Tom.
Make it full screen. Yes, please go ahead.
Good morning, everyone. My topic of today's presentation is corneal ulcer following exposure keratitis. Moderator is Dr. Pushpa Kumari. So, start with chief complaint. 50-year-old Hindu female housewife referred from burn ICU for redness and discharge from the left eye since 2 days. Instead of presenting illness, there is alleged history of accidental burn at home on 30th March 2022, and for this she was admitted in IG Burns ICU. Then she was referred to ophthalmology department for redness and discharge from left eye on 6th May. Past history was not significant. On general examination, there was 80% deep burn which was dressed. Patient was conscious but not cooperative and irritable. This is a photograph of my patient showing burn over the face and over the lid also. And on ocular examination, visual acuity, we are not able to take visual acuity because patient was not able to tell properly. On lid and magnesia, there was superficial to deep burn over the lower lid, and incomplete lid closure was there in right eye. Blink reflex was intact, but blink rate was decreased. Thus, phenomena was positive. On lacrimal sac, there was row plus absent, and in left eye, there was also superficial to deep burn on lower lid. Incomplete lid closure was there. Blink reflex was intact, blink rate was decreased, and Bell's phenomena was present, and lacrimal sac there was also row plus was absent. On conjunctiva, there was bulbar conjunctival congestion on right eye. On left eye, there was bulbar and palpebral conjunctival congestion. Emesis was there and mucopurulent discharge was present. On cornea, right eye, there were superficial punctate epithelial lesions on lower 1/3 of the cornea. On left eye, there were 2 into 2 into 2 mm size of corneal ulcer on central part of lower 1/3 of cornea. Margin was well defined. 3 mm infiltration was present around the ulcer with 3 mm epithelial defect. Fluorescent stain was positive. Corneal sensation was intact in both eye. Anterior chamber was apparently quiet. On left eye, a yellow color hypopyon of 3 mm size, which was mobile on changing the position of patient. On pupil, right eye, there was single central normal in size, normal reactive, both direct and indirect light reflex. Left eye also single central normal in size, normally reactive to both direct and indirect light reflex. IOP, digital IOP was normal in both eye and Sharma's test was 7 mm in both eye. This is my corneal diagram showing corneal infiltrate, epithelial defect, and corneal ulcer of 2 into 2 mm size and hypopyon was there. So my provisional diagnosis is right eye exposure keratopathy and left eye moderate central corneal ulcer following exposure keratopathy in 80% burn.
Gina, you can't be snow.
In others, mute because there's a lot of back noise.
Please mute everybody.
Yes, judges, please.
Yeah, Saba, I wanted to ask you, how did you check for the fluorescent staining on the bedside?
Ma'am, just keep the fluorescent strip over the cornea after dipping into the distilled water, and we check from a direct ophthalmoscope with a blue filter was there.
And how did you measure the hypopyon?
Ma'am, actually, this is just approximate value, ma'am. Cannot measure exactly size of the hypopyon.
Yeah, so you should just mention that this is an approximate guide because you have taken it all on the bedside and in an uncooperative patient. Okay?
Yes, ma'am.
And what makes you say that this is a moderate corneal ulcer? How do you grade corneal ulcers?
Ma'am, according to the size, because size was 2 into 2 mm, so this is mild, moderate, and corneal, severe corneal ulcer. In mild, size is less than 2 mm, and moderate 2 to 5 mm, and severe more than 5 mm, and depth accordingly. Like in mild, less than 20% depth, and moderate 20 to 50%, and more than 50% in severe corneal ulcer. And so accordingly, this I also say, this is moderate corneal ulcer.
Very challenging case, Sabha. So whenever you're describing the corneal diagram or while you're describing the cornea in your examination, do not mention corneal ulcer there. You have to describe what is the epithelial defect, whether there's an infiltrate, how deep is the infiltrate. And this mild, moderate, severe, I don't think is just based on the size. It's also on the depth and the severity of the infiltrate, any satellite infiltrates which are present. So the severity is not actually mild, moderate, or severe always. It might be a peripheral ulcer, it might be a central ulcer. So that depends upon that. And it is a challenging case, yes. And what was your plan of management after this?
Ma'am, on right eye, will advise taping of eyelid and artificial teardrop, and left eye will do bedside corneal scraping, then send for 10% QH mount, and after making SPR, will send for gram staining, and according to this, will further manage the patient in left eye.
Try to establish the microbiological diagnosis, but sometimes in uncooperative patients, it's difficult to scrape. So be careful for that.
Here in such cases, you have to remember that all your findings and management is just on a bedside evaluation. So you have to keep that in mind. And the second thing, whenever you're presenting cases, and this applies to all the students, in fact, just take care that the patient's identity is not disclosed. you could just crop up the rest of the image and you can just, expose the relevant parts only. But that ethical aspect has to be kept into mind.
What is, if you are planning a tarsography or anything, what is the single most important simple step that you can take right now and save the eye?
We'll do conjunctival flap we can make in the left eye.
If patient is not fit for anesthesia, general anesthesia, local anesthesia, and you just want to save the eye in an exposed case, what would you advise bedside?
In right eye, I will advise for taping of eyelid, ma'am, to protect the cornea, and artificial teardrop to prevent the desiccation of cornea.
That's right.
Madam, unfortunately, I am Dr. Puspa. Unfortunately, we lost that patient. Initially, after taking the gram culture report, stain, it was gram positive initially. So we started the treatment. After 1 day, it is improved. But very next day, that ulcer perforated and is a loss of AC. So we had planned for suture tarsography, but very next day, patient expired. So finally, we lost.
80% burns is very severe, I doubt.
But we survived for 40 days, 45 days. Because we have very good burn center here. But still we lost it, unfortunately. And the purpose of showing the whole body, I actually wanted to conceal the identification, but she wanted to show the burn case in ICU. That is the purpose. Otherwise, we have concealed. Okay, thank you.
Okay, before we go to the next, just when Lakshmi Priya is getting ready, I have you make just two minor comment. How is the 2 into 2 into 2? It's not 3-dimensional. We just measure length and breadth. And the hypopion is never presented in the frontal view. You need to, if you're drawing a diagram, you should section. Then in the, you can show between iris and cornea, it's not in the frontal view. And you describe 2 into 2 into 2. It is not length and breadth only, it's not height.
No, she has presented in both frontal and slit view. Actually, in this case, it is not possible. If you have handle slit lamp, we can present in a better way.
No, but still, whatever it is cannot be 3-dimensional. 2 into 2 into 2. She's described
2 into 2 and depth. Length and breadth and depth.
Depth we can't describe.
Depth we can't measure.
Depth we can't describe here. So it is only the size, vertical and horizontal.
Lakshmi Priya can start the screen sharing.
Start, ma'am. Hello.
Yes.
A very good morning to all. I am Dr. Lakshmi Priya Samantray from MKCG Medical College, guided by Professor Dr. Suchitra Das. Patient, I am presenting a case named Sanjukta Digal, wife of Abhilash Chand, 22-year female, coming from Gosaninwaga, Odisha Service Blind School, Ganjam, with chief complaint of pain, watering, photophobia in left eye for 25 days. Presenting this patient was apparently all right 10 days back. To start with, she developed diminution of vision in both eyes, where left eye is more than right eye, associated with progressive visual blurring, photophobia. She complained of sudden onset of pain in her left eye, associated with redness, watering, photophobia 25 days back, for which she came to eye OPD and was admitted. And there was no history of any eye rubbing or bilateral itching. Past illness, no history of diabetes, hypertension, any other systemic, no history of any use of spectacle or contact lens or any ocular surgery was found. Family history, she has 7 siblings, out of which 3 having similar history and not associated with any other system. Her birth history was uneventful. Coming to general examination, patient was conscious, oriented to time, place, person, with BP pulse was normal, no pallor, icterus, clubbing, lymphadenopathy was found, and all systemic examinations were within normal limit. Coming to ocular examination, visual acuity in right eye was counting finger 1.5 meter with pinhole, no improvement. In left eye, it was CFCR with no improvement. IOP was 12 mmHg with NCT and 15 mmHg with NCT in left eye. Retinoscopy finding in right eye, there was scissoring reflex. In left eye, reflex was faint due to corneal haziness. Lid and adnexa in right eye, it was normal with no papillae. In left eye, it was also normal. Then coming to anterior segment, conjunctiva was quiet in both eye. In right eye, cornea was clear with corneal thinning present and corneal apex inferinasally of size 5 mm. Stromal stare was present inferiorly. As anterior chamber was deep in both eye. Iris pupil are with a normal limit. Lens also clear. Then coming to external examination, on down gaze, we found Munson sign by putting the torch light in temporal side, we found Rizzuti phenomenon. Under slit lamp examination, we found central corneal scarring, and by doing keratometry, we found irregular keratometric myos. Then coming to keratometric finding, K1 in right eye was 62.75, K2 was 68, in left eye it was 55, and K2 was 67.25 diopter. Then come to autorefraction, in right power was minus 17.75 and cylinder was minus 6, in left eye it was minus 22.25 and minus 10.50. And then on distant direct examination, oil droplet sign was present in right eye and was faint in left eye due to corneal haziness. Was within normal limit. So out of these examinations, my provisional diagnosis is severe keratoconus in right eye and severe keratoconus in left eye with resolving hydrops. Thank you.
Can you switch on a video? Please, whenever the presenter is presenting, please switch on video and audio, unless the bandwidth is a problem.
I would just like to now ask you, how are you going to manage this case? What further investigations and what treatment will you advise?
Ma'am, first in right eye, as there is severe type of keratoconus, first we will try to give BCVA, best corrected visual acuity, but there was no improvement. So we will try for contact lens. But this patient belongs to a poor. This is from a blind school, so we have planned for dark in right eye, but in left eye, as it is hydrops is present, so it is an advanced case. So we will, again I am repeating, this is from blind school, so we penetrating keratoplasty for left eye.
Any other investigations you would like to do before you subject to patient to a surgery? It's not a routine intraop, but specific to keratoconus. Anything else you would like to do?
And we will do keratometry finding, we will measure, then we will see the size of the cone so that we can put the graft. Then we will rule out the routine investigations will rule out. Then
do you think there is any role of a pentacam in these cases?
Yes, ma'am. Yes, ma'am. Actually, I am presenting like the case, so I just not mentioned the pentacam.
No, but in the further management, you would like.
Yes, ma'am. We can use pentacam to see the where is the stiffening is present and where is the thinnest area, so that we can stitch according to that. And after also surgery, we can use pentacam to see the corneal topography, so that where is stiffened, then we will use that knot. If there is flattening, we will type the.
Well presented, Lakshmi.
Thank you, ma'am.
First of all, I would again reiterate that the identity of the patient need not be disclosed. It was very elaborate, so preferably avoid that. And okay, so what is the role of contact lenses in such cases?
Ma'am, contact lens will decrease the that photophobia, watering, and corneal irritation, and also it decrease the curvature that is protruded in keratoconus. So it will touch the cornea and decrease the stiffening area of the cornea, so that it is help in increasing the visual.
Contact lens. What are the types of contact lenses that you're talking about, right?
Ma'am, we can use rigid gas permeable contact lens, Roche design, Super design, and Nikon design, posterior bicurved lens design, and ma'am, piggyback lens we can also use.
So when we are asking this patient, this is a case of corneal blindness is what I've understood, and that is why the patient is in the blind school. So two things is, one, just try a contact lens for this patient, whether a mini scleral or a rigid gas permeable in the right eye, and see what is the best corrected visual potential there. And this patient might not be in further required to be in a blind school if that can be possible. So you'll know what kind of a visual potential you're looking at. And secondly, the 3 siblings that they have, the child has, also need screening. Okay, so we also need to ask you as a treating physician, you need to take care of those 3 other siblings also, because this is known to have genetic predisposition, especially in siblings. So that is one word of advice.
In fact, I would rather say that you should have the entire family screened, not only the 3 who have.
Ma'am, actually, yes, ma'am. Her parents are not.
Yes, should be screened.
Not presenting like similar history, and her she has also 1 child, but she is also normal. Only her family, they have 8 brother and sister. Out of 4 are affected.
So all 8, and especially the 4 affected, they should also be screened and treated.
So just one more question if we have time. What is the importance of taking history of pregnancy or lactation or trying to
Yes, ma'am. Yes, ma'am. Because in cornea, we have receptor of alpha and beta for estrogen, progesterone, and androgen. So if estrogen amount increases in a primary stage of pregnancy, it will increase the amount of matrix metalloproteinase 9 level, which will increase the collagenase level, and that will destroy the corneal stroma. But and later in pregnancy, the progesterone amount increases, that will antagonize the effect of estrogen. So the keratoconus progression will stop. That is the importance.
So in reproductive age group for females, this history is also important.
Yes.
Thank you.
Mona Lisa, can you share your slide? But I don't know whether the just intuitiveness, I did not notice whether the keratoconus going to blind school is very unusual. Is the fundus normal?
Yes, my fundus was normal. But her reason was...
Like, what do you think? Why I asked about fundus?
Ma'am,
association?
Ma'am, there is myopic association, so there may be myopic changes. But in
myopic will not lead to again blindness. Is there
yes,
any?
No, ma'am. Actually, her vision was so low, so for that reason, maybe she is in blind school. Not diagnosed. She was just diagnosed first time in our hospital. So maybe
they can have associated RP. So that is
yes. Yeah, I mean that. I was expecting that RP is not myopic will lead to blindness.
That is exactly where, Lakshmi, you can make a difference. That patient doesn't deserve to be
Video. Mona Lisa, you can proceed.
Others, please mute. Mona Lisa, can you make full screen?
Yes, ma'am. Yes, ma'am. Good.
Please switch in your video if you're presenting.
Okay, ma'am. Yes, ma'am. So, good morning, all. Today I'll be presenting a
case. Not yet full screen.
Full screen. Yes, ma'am. I have done full screen.
No, we don't see full screen here.
Yeah.
Yes, go ahead.
Yes, ma'am. Good morning, all. Today I'll be presenting a case. My case is of a 55-year-old male, profession by actor, came from Jajpur to our hospital OPD with the chief complaint of redness and diminution of vision in his right eye for 6 months, and which was associated with the irritation and photophobia. He was apparently all right 6 months back, started with the redness, diminution of vision, and irritation and photophobia, which was insidious in onset and progressive in nature. he was treated with some topical antibacterial, antifungal, and antiviral medication locally, and also he treated with the topical steroids. And he has also redness in his right eye on and off since 6 years back, and he has no history of diabetes, hypertension, or no history of trauma, no skin lesion or recent fever or malignancy, or he was not on any immunosuppressant medication, and also he has no history of any ocular surgeries. He was a non-smoker and also has a mixed dietary habit, and he has no history of similar complaint in his family. He was well built on the general examination, where within the normal limit as done, and also the systemic examination was also within the normal limit. On ocular examination, his face was externally normal, and head was erect, and facial symmetry was bilaterally symmetrical, and his ocular position was orthopedic in both the gaze. Then his ocular motility was full in all directions, and his best corrected visual acuity as seen was hand movement positive in the right eye, and perception of light was positive, and projection of rays was accurate in all the quadrant, and left eye was all within the normal limit. Intraocular pressure was digitally normal in both eye. Lacrimal duct was patent in both the eyes. Then again, the anterior segment of the left eye was not within the normal limit, but in the right eye, I will describing in the next slide. So in the right eye of the patient, it was seen as it is the diffuse slit lamp photography of the right eye, which shows the epithelial defect of 7.5 into 5.2 mm, which has geographic or map-like configuration, and it has the flat margins, and it has thinning in the central cornea, which is approximately 40%. Also has the deep vascularization inferiorly between the 6 to 7 o'clock position, and superiorly between 12 to 1 o'clock position, and also has the central leukomatous scarring. As we did the fluorescent staining, it also taken the effect defect, also taken the stain, which is positively epithelial defect is seen, and his corneal sensation also was decreased. This is the schematic diagram of the right eye as we seen in the slit. Then on the basis of my clinical findings, my diagnosis is geographical corneal ulcer, mostly probably due to herpes simplex virus. Thank you, ma'am.
Yes, Dr. Monalis, I just wanted to ask you, did the patient have any documents of the previous treatment? You mentioned all those different groups of drugs. So did the patient show you any documents?
Yes, ma'am. He has treated with steroid, he told. As it is a long-term symptom he is having since 6 years, so he has treated with antifungal, antiviral, all types of medication.
No, but did the patient have the documents? So that could give you an idea exactly what antifungals, what topical steroids.
No, ma'am, he has not brought the documents, but as we asked him that as he treated with the drops that tapered, he told tapering dose he treated. So that
actually, because when the patients are on such long-term treatments and they don't have documents, then it is very, very difficult to actually make out what the patient has been using and whether the treatment is having any effect, either good or bad, on the condition. So that needs to be very clearly presented when you present a history.
Yes, ma'am. One document only he brought, a recent document before 6 months, not long-term document from another hospital. Was treated with the antifungal, antibacterial, and this is what I told with the steroid also, ma'am.
Okay. You mentioned about the vascularization, superficial as well as deep. So what do you think? These are good signs or these are not good signs for the treatment and prognosis?
Ma'am, actually, as the patient has a long history, so he must be infected with like stromal involvement. So there may be a chance of devascularization as the stromal component may have involved previously. When it came to us, it was only the epithelial defect with the stromal scarring. So
is the vascularization a good sign for cornea surgeons or not a good sign? How does it impact your treatment and prognosis, the visual prognosis, everything?
Ma'am, actually, stromal involvement, when it occurs.
You skip the vascularization. She's asking about vascularization.
Yes, yeah, no, ma'am, it's not a good sign actually.
Okay, how do you propose to manage this case?
Ma'am, manage this case starting with the B scan. We'll manage to see the posterior segment that is, it is not seen in the right eye. So then again, I'll start with the acyclovir 3% eye ointment to see for the 1 week. Then after that, I will call the patient for the review. Then again, I will give him 1 week. After 2 weeks, if he doesn't heal, then again I will do the bandage contact lens. Then
anything else along with the antiviral would you like to give? Only the antiviral, something else also?
No, ma'am. As it is the epithelial defect, we will start with the antiviral, topical antiviral only, ma'am.
Okay. Dr. Purvasha.
So just in continuation with Purvi Madam's question, if they don't have a document, how would you try and find out what medication have they been using? So are there any clues in the history that you can just find out? When you see that
he has brought one document of only 6 months back.
Suppose there's no document and they have just been going around and people have prescribed, as you said, antivirals, antifungals, this, that, everything. So which can you ask for the type of drug which was given, the number of times it was given, or any other route of administration? Can that be a clue, especially in antivirals? Any kind of an eye tube or an eye ointment which they have been asked to put 5 times a day, or a tablet which has been asked for by the doctor, prescribed for 5 times a day, that is usually the clue for a kind of a viral infection being treated, that the primary treating physician has had some suspicion of virus. Okay, so take that into consideration. Even if they don't have the document, you can ask them to bring the old bottles and things like that. Keep them on regular follow-up. Such patients will be chronic patients because these episodes recur. And just based on your examination, you've done a fluorescein stain and there's an area of thinning. Is there any other test that you would like to do on your fluorescein while you've put your fluorescein to see if any further management or your management will change accordingly? While doing a fluorescein test, would you like to comment on some other thing that you would like to see, especially in cases of thinning? There was a central area of thinning there. So what test is it called based on your fluorescein?
We will do, ma'am, serial test if there is.
Right. Yes, so that becomes important there. If it's leaking, then what happens?
It might be a corneal perforation.
Yes, so it's either an impending perforation or a frank perforation, then your management immediately changes. And any case of epithelial defect with infiltrate, I think corneal scraping is a must. Even if it's 100% looking like a viral, you have to do a corneal scraping to rule out any other microorganism. Okay?
Yes, ma'am.
Neha, can you please start sharing? We are losing time in the sharing part. So, yeah, start, Neha.
A very good morning, teachers. Myself, Dr. Yamijala Neha Shrija, under the moderator, Dr. Shika Mishra, Assistant Professor, IMS in some hospital. Today, I'm going to present a case of a 38-year-old male resident of Bhubaneswar came with a complaint of pain in the both eyes since the 3 days, with a left eye greater than the right. He came with a complaint of left eye pain more than right for the past 3 days, which was high in intense pricking type of pain, aggravated in the morning after awaking from the sleep. It is associated with the photophobia, watering, redness, and blurring of vision. There is no history of trauma. There was similar history in the past, which was on and off for the past 2 years. and patient has not given any history of usage of drugs, or there was no document that he has produced. Personal history was normal and there was no significant family history. On ocular examination, head posture is normal, facial symmetry is maintained, eyelids and adnexa were within normal limits, ocular motility was full and adequate in all the directions of gazes for both the eyes, and lacrimal apparatus was patent. On examination, uncorrected visual acuity in the right eye is 6/24, which was improved to 6/9 with pinhole, and near vision is N6. And in left eye, it was 5/60, improving to 6/12 with a pinhole with a near vision N6. Conjunctiva was normal in the both eyes. In right eye, the epithelium has microcystic edema, stroma has edema, and endothelium has shown guttae and pigments. And in left eye, epithelium has a ruptured bullae and the microcyst with stromal edema and guttae and pigments that are present on the endothelium. Anterior chamber is deep and quiet in both the eyes, with the rest of the details, iris, pupil, and lens within the normal limits. IOP on digitally seemed to be normal. On fundus examination, in the right eye, the media was clear and fundus was within normal limits. In left eye, it was hazy due to central bullae. This is a clinical picture of a right eye in a slit view showing the hazy cornea with microcystic edema and few guttae on the endothelium. This is a picture that we can see there is microcystic edema, stromal edema, and the guttae. And this is a clinical picture of left eye, slit view, showing a ruptured bullae that is present in the pupillary axis of with surrounding microcystic edema. Guttae are present on the endothelium, and the stromal edema is also noted, and with few pigments that are present on the endothelium. To summarize, this is a case of a 38-year-old male came with a chief complaint of pain in the both eyes, left eye more than right, for the past 3 days, increasing more on waking up from the sleep in the mornings and feeling relieved by the evening, with the similar complaints in the past. And on examination under slit lamp, we could see a ruptured bullae and microcyst and guttae and associated with pigments in the left eye, and microcystic edema, stromal edema, and guttae in the right eye. With this, we came to a provisional diagnosis of bilateral Fuchs corneal endothelial dystrophy, stage 3 in the left eye and stage 2 in the right eye, with left eye recurrent epithelial erosions. Thank you.
Well, I think nice discussion judges going on, but please restrict to this 4 minutes discussion by the judges, because we need to give the next year's 10:40.
Somebody can just stop us when 4 minutes are over. No issues.
I think I'll put the timer now. Presenter.
Yes, ma'am.
I would just like to ask, you mentioned about the past history, that similar episodes were there in the past, but
Yes,
there is
ma'am.
no history of treatment. So
Yes,
how
ma'am.
did those episodes get relieved?
Ma'am, it can be because of microcystic edema, ma'am. With time, they might be relieved, and so.
But he never approached any doctor for during those 2 years.
No, ma'am, he didn't give us any history, and he didn't provide us any documents. He was saying he had pain, but he was giving an excuse of COVID in between.
What do you think is the cause of the pigments on the endothelium?
Ma'am, pigments can be because of endothelium dysfunction.
So how does that lead to endothelial pigmentation?
Ma'am, the metabolism function and the barrier function.
Okay. how do you grade the dystrophy? You mentioned stage 3 and 2. So what
Yes,
are the
ma'am.
grades? Yeah.
In stage 1, ma'am, there will be corneal guttia that will be present. In stage 2, there will be associated stromal edema, and the epithelial edema also will be present, ma'am, microcystic. In stage 3, there will be bullae, ruptured bullae associated with pain. And in stage 4, there will be scarring, vascularization that can be seen, ma'am.
And how will you treat this patient?
Ma'am, initially we start with topical medication, ma'am, for the treatment. We can give 5% sodium chloride, hypersol solution. We can give lubricating drops for comfort of the patient. And we can note the progress, how the patient is improving with the time. And then if there is still the bullae are still there and he is not responding, then we can go for bandage contact lens, or anterior stromal puncture can be done, and we can follow up the patient frequently to know how he is improving to the treatment that we can give.
Dr. Purvasha?
Okay, so based on slit lamp
Yes, ma'am.
examination, what technique would you use to confirm your diagnosis?
And specular reflection technique can be used to see the endothelium, ma'am.
So did you do that?
Yes, ma'am.
So what did you find there?
Ma'am, they were corneal guttia that we had seen, ma'am.
Okay. And which investigation would you like to advise?
Ma'am, I would like to advise specular microscopy to know the count, the shape, morphology, if there is increase in the cell, decrease in the cell density, and to see the guttia also.
Okay. And would you like to comment on other parameters on the specular?
CD ratio, cell density.
Can you, Neha, can you answer this? So the next presenter can show this when you answering. Keep on answering, but just.
I should. Oh, okay, ma'am. Stop. Yes, ma'am. Ma'am, is it okay, ma'am?
Yeah, the next person can say, start sharing. Please answer to the question.
Yes, ma'am.
Please answer to Purvasa's question.
Dr. Shrija, you can keep answering.
Ma'am,
Forgot the question.
The specular parameters that you would specifically look at.
Ma'am, cell density, if there is any variation in the size, shape of the coefficient of variation can be seen. And we can, ma'am.
What is that called?
Coefficient of variance.
That shows that there is.
If it depends upon the value, ma'am. Normal value usually considered as 0.25 to 0.40. More than 0.40, the prognosis is poor, ma'am.
So what is polymerism and pleomorphism?
Ma'am, polymerism is increase in the size of the cell, and the pleomorphism is there is alteration in the shape of the cell.
Very good.
Okay, Harshita, can you start?
Yes,
Thank you.
good morning. Good morning, everyone. I'm going to
slides.
Good morning, everyone. I am Dr. Harshita from KIMS. I'm going to present a case of a 67-year-old female.
Can't see the slides yet.
It shows that you have started screen sharing, but the presentation is not visible. You can stop sharing and share again, perhaps.
Okay, ma'am. Good morning. Now, can you see, ma'am?
No, not yet.
Is Dr. Aarti ready with her slides? Maybe Dr. Aarti can present now. Is Dr. Aarti there?
Yes, ma'am.
Yeah, please start sharing. Dr. Harshita, you can try on your screens.
Yes.
Just check Okay, Aarti, start sharing.
Yes.
No, your slides.
Ma'am.
Dr. Aarti,
Yes, ma'am.
please start sharing. Harshita, you have to stop sharing.
I stopped.
Okay, Aarti, please start sharing. Or else Dr. Akshat, whoever is there. If Dr. Akshat is there, he can start sharing.
Yes, ma'am. Am I
Yeah,
audible?
please start. Yeah, please start. Dr. Akshat, you can start sharing.
Yes, ma'am.
Harshita and Aarti, please see what's wrong at your end. Yeah, fine.
Yes, make it full screen.
Are my slides visible and am I audible?
Make it full screen.
Is it full screen now?
No, no, no. Just go to the.
Yes, go to that icon.
From current slide, full.
Is it? No, I am doing.
Below there are 3, 4 slides.
Below there will be 3. No, not there.
No. Below, see that bar in the below, there are 3 icons. Yes, go to that.
Yes.
No, next. Yes.
Is it full screen now?
No. That one, you click on that.
Click on that.
Click on the icon below. Below.
Yes.
No, that one. Yeah.
I have clicked, but it is not getting full screen.
Okay, you proceed.
Yes, go.
Maybe we can see like this also. It's fine.
Sure. Just last. Is it now?
No.
Go ahead.
Okay. Good morning.
No problem.
Okay. Good morning, everyone. Myself, Akshat, primary DNB resident of LV Prasad Eye Institute, presenting a case of ring-shaped cornea infiltrate under the mentorship of Dr. Amrita Mohanty, consultant, the Cornea Institute, LV Prasad Eye Institute, MTC campus, Bhubaneswar. My case is a 46-year-old lady hailing from Medipur district of West Bengal, farmer by occupation, presented to us with the chief complaint of left eye pain, redness, photophobia, and blurring of vision since 2 months. History of present illness. A patient was apparently asymptomatic 2 months back when she noticed a painful diminution of vision that was gradual in onset and associated with redness and photophobia, for which she consulted locally 5 days ago and was prescribed topical medications that subsequently led to worsening of symptoms. There was no history of foreign body entry or any vegetative matter trauma, no history of using glasses, contact lenses, and no history of head injury. The patient is not a known case of any the patient is not a known case of any systemic illness like diabetes mellitus, hypertension, or any other systemic illness. The past illness, family history, and personal history of a patient are non-contributory, and patient is not aware of any known allergies. The current treatment which patient is on is left eye prednisolone acetate 1% 4 times a day, homatropine hydrobromide 2% thrice a day, moxifloxacin 0.5% 12 times a day, and orally paracetamol twice a day. Visual acuity examination of right eye was within normal limit with best corrected visual acuity of 20/20 and N6 for distance and near vision respectively. For left eye, distant vision was counting finger close to face, not improving with pinhole, and the near visual acuity examination was deferred. The external examination of the patient was within normal limits. So far as slit lamp examination is concerned, for right eye, both anterior and posterior findings were normal. For left eye, this is a slit lamp examination photo of left eye under diffuse illumination, which shows edematous eyelids with conjunctiva diffusely congested with circumcorneal congestion. The cornea shows a ring-shaped infiltrate of 8.5 and 8 millimeters in horizontal and vertical axis respectively, with the satellite lesions superiorly from 11 o'clock to 1 o'clock position. Also, there is a superficial vascularization of 270 degree from 4 o'clock to 1 o'clock position, and the central cornea is hazy with epithelial defect but no significant thinning. The pupil looks dilated, perhaps pharmacologically, since the patient is on home atropine and the details of iris also can't be appreciated. This is a slit lamp photo under fluorescent staining showing the epithelial defect of 9 millimeter into 8.5 millimeter in horizontal and vertical dimensions, and parallel pipe section showing the infiltrate of anterior 2/3 of stroma. The corneal sensation in both eyes were normal, and the Roplast test of both eyes was negative. The post-dilated examination of right eye was within normal limits, and left eye had a hazy media. So to summarize my case of 46-year-old female, 46-year-old female presenting with a history of redness, photophobia, and pain since 2 months back, worsening symptomatically with the currently prescribed treatment and a long-standing cornea ulcer with ring-shaped infiltrate, dry looking surface, irregular marking, is suggestive of left eye microbial keratitis, most probably of fungal etiology, and right eye emetropia. Other differential diagnosis presenting with a long-standing ring-shaped infiltrate are acanthamoeba keratitis, nocardia, and python. Thank you.
So judges, just 1 minute. Is Dr. Aarti or Harshita ready?
Yes, ma'am.
Okay, fine.
Yeah, actually, you can answer. You can answer when the judges are asking question. Somebody
So
else.
we can, maybe they want to refer to the diagram or something.
Okay, okay.
Yeah, I just wanted to ask one thing. You mentioned about the complaints as pain and redness and photophobia. So would you still like to say that these would be of insidious origin and gradually progressive?
Actually, ma'am, she has these. The main problem was diminution of vision. They were accompanying problem, but these problem escalated after she began her treatment 5 days ago after consulting locally.
So it was an acute and chronic type of a.
It was a chronic type of. Presentation that that increased symptomatically in last 5 days.
Okay. So how would you like to confirm your diagnosis now?
I would like to confirm my diagnosis by microbiological investigation following corneal scraping. Interim diagnosis can be based on the basis of smear examination of gram stain and KOH, and gold standard diagnosis is obviously culture, blood cultures, blood culture, blood agar culture, and chocolate culture for bacterial, if it is of bacterial origin, NNA for acanthamoeba keratitis, and SDA-PD for fungal keratitis.
And while the reports are awaited, what treatment would you start?
Ma'am, the reports of smear can come in 30 to 60 minutes. So it is suggested not to start an empirical treatment, rather wait means smear report come in 30 to 60 minutes. So we will start after that only.
Any first advice that you would like to give to the patient before you wait or you start? Anything else you would like to right away advise to stop anything that he is currently
Yes, ma'am. He is on prednisolone acetate 1% that she was prescribed. So that I would ask to stop at first instance.
Yeah, Dr. Purvashi.
Yeah, that is a very challenging case, Akshat. So was there any area of thinning around?
No, ma'am. Surprisingly, even in slit, even in optic section also, thinning was not there.
The peripheral area just near the limbus from 7 to 12 was kind of suspicious for thinning, just based on your slit lamp photograph. I'm not sure of the actual examination. So I was just asking that. So, so once you've confirmed your diagnosis, you would like to go ahead with the corneal scraping is what you said. Any other investigations would you like to go ahead with?
The investigations. Ma'am, since the patient looks for left eye, since the posterior segment examination can't be done post-dilated examination, so we will do B scan. And since the patient looks clinically for fungal, so we will also order biochemistry for random blood sugar.
That's
because
right.
And also the patency of lacrimal sac, since it is a long-standing ulcer. So chronic dacrocystitis can also be associated.
So what you mentioned, all these are important, and rho plus, which is negative, does not necessarily rule out NLDO. So that is
so syringing, we will do
yes.
syringing.
So you said corneal sensations you have checked.
Yes,
so was that relevant? Well, how do you
No.
check for corneal sensations?
It was not relevant, but for the completeness of corneal examination, I did. We do it with the cotton wisp introduced temporally and asked for and look for blinking. That is the way we check.
It's almost the entire cornea which is involved. So it is expected that corneal sensations might not be so accurately present, or it might not have the exact interpretation.
Yes, ma'am, sure.
Okay.
Sure, mostly it is relevant in the case of viral keratitis, but no.
Okay. Thank you.
Aarti, who is coming next? Aarti or
Harshita.
Harshita?
Ma'am, I'm coming.
Yeah, please do.
No, Harshita, we can't see it still. If Aarti is there, maybe she can try. Then Harshita, you can try some other device.
Yes, ma'am.
Aarti, please share.
Yes, ma'am. I'm trying.
Harshita, try some other device.
Okay, ma'am.
Harshita, you have to stop screen sharing. Yeah. Aarti, we can't see your screen.
Yes, ma'am. Then is it visible? Ma'am, is it visible?
No, but you should have opened that. Now she's opening. I don't know whether it will come. You should have
The
kept
screen is visible. You have to open your presentation.
Ma'am, there is some problem, ma'am. I'm unable to.
No. Otherwise, you stop sharing, then open their slide before you share. Open
Yes.
the slide, keep in the desktop, minimize it.
Open that presentation, then minimize and keep it in the desktop. Then you go to Zoom, go to share screen, and then you go there.
Yes, ma'am. I'm good.
Yes.
Can you see the screen?
Yeah, make
Yeah,
it
you can
full
proceed.
screen.
Otherwise, they can proceed like this also. It's okay. Since we are wasting
Thank you,
time.
ma'am.
Yeah, you can proceed.
Yes, ma'am. Good morning, everyone. Myself, Dr. Aarti Vishwar, presenting a case of traumatic keratitis. A 50-year-old male came to the eye OPD with chief complaints of pain, redness, lacrimation since 15 days. History of present illness. Patient was apparently all right 15 days back. To start with, he developed pain, redness, lacrimation, and diminution of vision in the left eye following injury while cutting wood. He attended that local hospital. He was attended at local hospital. Upper eyelid laceration was repaired, and systemic and topical antibiotics was given. He had no history of any prolonged illness like diabetes, hypertension, and TB. Patient was non-smoker, non-alcoholic, and belongs to low socioeconomic status. Coming to the general examination, patient was well-oriented to time, place, person. All the systemic examination were within normal limit. Then coming to the ocular examination, in the right eye, visual acuity was 6/6. Near vision was N6 2 diopteric spherical presbyopic correction, and in left eye, visual acuity was counting finger close range. Position of head normal in both eyes. Face and eyebrow bilaterally symmetrical. Extraocular movement normal in both eyes. Right eye anterior segment was within normal limit, and in left eye, upper eyelid is edematous, laceration incompletely repaired. Lower lid edema, ectopion was present, matted eyelases and discharge was present. Palpebral height 10 mm in right eye, left eye it is 15 mm. Lacrimal apparatus, puncta, patent, regurgitation absent in both eyes. On eversion of the lower lid of left eye, wood particles were found embedded within the fornix. This is the picture of the wooden pieces from the fornix. Then coming to the conjunctiva and cornea, it was normal in right eye, and in left eye, bulbar conjunctiva, circumcorneal conjunction was present, palpebral and fornices was congested. Then coming to the cornea, in left eye, size and shape normal, central epithelial defect of 6 × 5 mm with distinct margins with surrounding infiltration of 8 mm into 8 mm was present. This is the fluorescence staining diagram of the cornea. Curvature was flat centrally. Transparency was not, cornea was not clear due to epithelial and stromal edema. Sensation in left eye diminished throughout, and vascularization, superficial vascularization present 360° along limbus. Then coming to the anterior chamber, it is normal in right eye. Left eye details could not be appreciated due to edema. Iris, the pattern and color was normal in right eye. Left eye could not be appreciated clearly. Pupil, circular, round light reflex present in right eye, and left eye could not be appreciated. Lens also could not be appreciated in left eye. Intraocular pressure normal in right eye. In left eye, it is divided by
reverse and
fundus within normal limit in right eye. Left eye it could not be seen. So my provisional diagnosis is left eye traumatic upper eyelid laceration due to retained foreign bodies associated with keratitis.
Yeah. Then use it now.
Then take home message: meticulous approach to a patient of injury can avoid inadvertent complication to the eye. Thank you, ma'am.
Send me the picture.
So how will you treat this case now, Dr. Aarti?
Yes, ma'am. Now upper eyelid laceration can be repaired properly, and after removing the foreign bodies, we can treat the ectopion also. And for corneal abrasion and keratitis present, we will treat this case by giving topical antibiotics, cycloplasics, and antibiotic eye ointment also.
So out of all the three managements, which will you start first? Repair, upper lid, or the corneal management?
Ma'am, we can start first corneal management, but ma'am, ectopion should also be corrected. Otherwise, as it is a case, as it is a cause of it leads to non-healing, so we should treat the ectopion first, ma'am. And simultaneously, we can repair the eyelid also, upper eyelid.
What type of a repair would you do with the upper eyelid?
Ma'am, we can with 50 silk, ma'am.
Any care would you like to take in the repair? Just suture the cut ends, or some precautions you would like to take?
Ma'am, we will repair the lead margin for proper apposition of lead margin, ma'am, by doing proper apposition of lead margin.
Dr. Purvasha, yeah.
This is very interesting to see so many foreign bodies after so many days which are lodged inside. So that was a good finding that you helped with patient's management. And any role, any role of corneal scraping here?
Yes, ma'am. We can do corneal scraping and we can do also smear and we can send for culture, ma'am. As it is a injury by vegetative matter, cavage mount should be done, and also.
So any foreign body that you remove needs to also go for microbiology examination. So that is again important. Any infiltrate with epithelial defect that you see, again you have to do a corneal scraping. Here, which is the most common organism that you're suspecting if it's a microbial keratitis?
Yes, ma'am. It could be fungal also. As it is.
Right.
Yes, ma'am.
So you have to consider that kind of management also.
Yes.
Fine. Thank you.
Shita, can you log in now?
Yes, ma'am. Yes, ma'am. Okay. Good morning, everyone. I'm Dr. Harshita Parchuri. I'm going to present a case of a 67-year-old female, housewife by occupation, came with the chief complaint of pain, headache, redness in left eye since 5 days, and diminution of vision since 5 months in left eye.
Your slides are not moving. You need to go to that slide.
Patient was.
You go to the second slide. Otherwise, is not moving. Yes. Yes.
Okay, ma'am.
Fine.
Patient was apparently fine 5 days back. She had a throbbing pain, which was sudden in onset, radiating to the forehead, and with no diurnal variation or no aggravating factors, which is relieved by normal analgesics. And history of redness was present since 5 days, which is not associated with watering or any discharge. History of headache since 5 days is not associated with vomiting. History of diminution vision was since 5 months in left eye for both distance and near vision. It was insidious in onset, gradually progressive over months, but it was aggressive due to the recent attack. There is no history of colored halos, no history of any spectacle usage in the past. In the past history, patient had a cataract surgery done in right eye in 1 year back. Patient is a known case of hypertension and diabetes since 10 years on regular medication. Family history is not significant. Personal history, patient was using diabetic and salt restricted diet and no history of any addictions and normal bowel and bladder habits. General examination, patient is conscious, well oriented to time, place and the person. Average build and nourished and vitals are normal. Systemic examination, no abnormality detected. Ocular examination, normal head posture, no head tilt or chin lift, normal facial symmetry. Visual acuity of the left eye, there was a perception of light is present and projection of rays are present in all the 4 quadrants. And intraocular pressure with the help of appellation tonometry was done at 4 p.m. was 50 mm of mercury in the left eye. In ocular adnexum, lid edema was present, and under the help of slit lamp, congestion was present. In cornea, there was a microcystic epithelial edema is present. Surface was very hazy and fluorescent stain was negative. And other details couldn't be elicited due to the haziness of the cornea, and sclera was normal. Anterior chamber, it was normal depth, and there was a whitish floating particles floating in the aqueous humor, suggestive of lens. Iris was normal, and remaining details couldn't be elicited due to the hazy view. Pupil was 3 to 4 mm after dilatation. It is round, regular, very sluggishly reacting to the both direct and conjunctival light reflex. In the lens details are Very hazy anterior lens capsule appears to be intact. There was a milky white opacification seen in the cortex, suggestive of liquefaction. In the gonioscopy, couldn't be done due to pain. Fundus, there was a no view. In the right eye, the visual acuity is 6/6, and other findings are normal. Only in the lens there was a PCIOL. So that my provisional diagnosis would be lens. In the left eye, it is lens-induced glaucoma. In right eye, it is pseudophakia. This is the patient.
हमारा फैसिलिटी कितना अच्छा है जिसमें हम लोग बंद पेशेंट का इतना कर रहे हैं हमें सबसे बहुत ब्लेस्ड पता है पेशेंट के लिए तुम लोग इसे तेरे जाने के लिए पूछना भी
Yes, ma'am. Yes, ma'am.
ये जजेस के
Some background conversation there.
इधर को कौन बना था खुद ही बोली थी लगाने को लेके हमको दिखाना है कि कितना पर्सेंट बाहर है फिर वो बोल
पागल औरत है इसलिए मैं उससे कभी उसके बात सुनता नहीं हूँ आप ही लोग
Please unmute. Please mute. Yeah, please talking. Please mute.
फंसाने के नहीं वो आप अपना दिखा रहे हैं
So in a diagnosis, you mentioned about lens-induced glaucoma. So which type of lens-induced glaucoma is this?
It is probably a phacolytic glaucoma, ma'am.
What are the other types of lens-induced glaucomas?
Phacomorphic and phacotoxic and phacoanaphylaxis glaucoma.
So why do you say it is phacolytic?
Due to, you can see in the anterior chamber, there is depth is normal, and there is a whitish lens particles could be seen, ma'am. So that I'm thinking it's a phacolytic glaucoma.
You mentioned about the spectacle usage. So with respect to glaucoma, what other history do you ask regarding spectacles? With respect to any glaucoma, when you're what other history regarding spectacle use do you ask?
Frequent change of glasses. Frequent change of glasses.
Anything else?
What kind of refractive error exactly?
Which type of glaucoma is associated with which type of a refractive error? Okay, so what will you do for this patient? Primary treatment and planned treatment.
Ma'am, intraocular pressure should be reduced, ma'am. Mannitol will be given for the mannitol is given to this patient immediately, and oral carbonic anhydrous inhibitors are also given, ma'am, and topical drops, topical antibiotic and topical steroid drops to reduce the inflammation is given. After the intraocular pressure is reduced, we have planned for the cataract surgery.
Any precautions you would like to take when injecting mannitol, especially considering this patient's history?
Patient is a diabetic, will be and hypertensive.
So, what if the patient's blood pressure is 190 by 100?
No.
So you'd like to take the blood pressure, ensure
and blood pressure and yes, ma'am.
Just right away give.
Yes, ma'am.
Dr. Purvasha.
That is Harshita.
Ma'am.
Yeah. So, how did you measure the intraocular pressure in this case?
By the help of apparition tonometry. We have measured.
Okay, so that is that is accurate? You think that was an accurate measurement?
Yes, ma'am. Gold.
And any corneal edema that you noticed?
Yes, ma'am. Corneal edema was present, ma'am. Patient is having corneal edema.
Okay. And any other management you would do apart from this systemic management before taking up the patient for surgery? Any investigations?
Checking for blood patients are diabetic and hypertensive, ma'am. We'll be checking those and will be planned for the surgery and reduce the intraocular pressure and will be planned for the surgery.
What were the B scan findings? Any findings that you could see?
No, ma'am. B scan was normal, ma'am. Retina was on and no any vitreous echoes also we couldn't be seen.
Any other differential diagnosis you have kept apart from lens-induced glaucoma?
Ma'am, it can be like acute angle closure glaucoma also and neovascular glaucoma also. It can be differential diagnosis and glaucoma associated with any trauma.
Thank you.
Thank you, everybody.
Everybody video on, so he'll take a screenshot of the.
Thank you all presenters and Dr. Purvi and Dr. Purvasa for a wonderful discussion. Maybe we can go to the next session now.
So Dr. Purvasha and Dr. Purvi, thank you so much. We learned a lot. I hope the PGs take some lessons from here and get better every time if we carry this forward. And thanks a lot. And please send in your scores to me after the end of the session. Yeah. So now we have a guest faculty. We have a guest speaker rather. She's Miss Swati Pandey. I'm having the same problem. Yeah. So I welcome Miss Swati Pandey. She's the Postmaster General of the Mumbai region. A very unusual person, or rather, I would say the kind of person I would really like to address our young freshers out here. Because though she's passionate about that letterbox, she's somebody who really thinks out of the box. So with an experience, yeah. So welcome, Ms. Swati. So with an experience of more than 24 years, she is not only a career bureaucrat representing Indian Post with her experience in atomic energy and the Ministry of Information Broadcasting. She has a whole lot of other achievements to her credit. So this is a ubiquitous letterbox, the classical boxes that we have seen in our childhood. So this is again a dreary inside of a post office, the one picture that we usually carry, maybe even worse than this. And so who do we think a PMG will look like? Maybe somebody like this. But let's see how our PMG looks like. She's somebody who relishes thinking out of the box and breaking silos every day. So just see how flamboyant she can be. You see her everywhere other than a letterbox. I mean, though she's completely devoted to that letterbox, you see her wherever you want. You wish to see anybody. And she has a lot of achievements to her credit. Recently, she has been working on the Kamathipura Sex Workers Bank on. This is a bank completely dedicated to the cause of the sex workers there. And she literally goes into the lives. She literally lives part of the days with them. So that is how she motivates them. And when you have a woman reaching out to women, there's nothing better than that. And now her dream project to restore the heritage building of the Mumbai GPO, and also computer classes and art therapy, a part of project for all for smiles. Then you can see her in that vibrant yellow sari on that tableau in the Republic Day. Then she's equally passionate about the textile and fabrics of India. She really goes out to promote them. And finally, the Rajat Kamal that she got for her movie. And this is, I think, the motto she lives by. So over to you, over to you, Swati. Welcome.
Thank you very much. I think it becomes a great honor for me to come and address a gathering of doctors. So my dear friend Devi, who has been a childhood bud, a chuddy bud as you call, addressing me as Dr. time and again. Not a very different term for me because my parents are doctors. Thankfully, I skipped the family profession and I took something up new. And as Devi said that, you don't need to live in a square box, because when people talk about bureaucrats, it's about people who are lethargic or so rule bound, and off late in the newspapers, all of you must be reading the bureaucrat who was walking his dog in Delhi, asking the sports people to leave so that he could walk his dog. So that's the general image of bureaucracy. But I also want to say that it depends on an individual, choice. The government gives you so much of flexibility also. And I know you've heard this term, correct, flexibility, because you are not answerable to anybody. So you can define what is it that you want to do. And in one of these journeys, of course, I made a film. I'm not a trained filmmaker. I was an anthropologist before joining civil services, 1997. But when I met a lady, my daddy is from East Bengal, or the current Bangladesh. I met a lady who was then 93, called Rama Khandwala, and she was a soldier in the INA, Indian National Army of Subhash Chandra Bose, meeting Bose, talking to him, getting inspired by him. How many do you know people who are alive today who have fought this battle with Netaji? I'm sure you can count only a few, because the lady I talked was 93 already. So I made a movie on her, a movie about my passionate journey of Netaji, because I am an Odia Bong. My dad's Bengali, my mom's a Odia. So Netaji had that, I could connect to him, and all of us here, I'm sure, connect Netaji because of his Kathak growth. So, that movie, of course, went to all film festivals, Berlin, Chicago, Cannes, and it eventually won me the National Film Award, Rajat Kamal, on my debut attempt. But this is not why I'm here today. I'm here today to talk about my project, All for Smiles. I have named this project. It was not named anything. This was not funded by anybody. It is not even self-funded. Because, when I was doing Sukanya Samriddhi, if you have girl children under the age of 10, most of you would know that there's something called Sukanya Samriddhi accounts, which is for the girl child from age 0 to age 10. When I was doing this, I happened to chance by the Kamatipura post office also. And when I was opening accounts, because we have these accounts drive, one girl, I asked her that, why don't, and I saw numbers not working in Kamatipura. And I asked my postmaster, why are numbers not blimping well in Kamatipura? They said, I don't know, madam. This was a gentleman then. A postmaster was a gentleman. So he said that nobody comes, and this area is of sex workers. Then I went in. I wanted to meet these women and ask them why are they not investing? Because these are small investments. Postal Savings Bank is a small savings bank for people who have day-to-day income and not for the, employed class. Then they told me that, madam, us, we hold a taboo that is beyond the reservation category also. Nobody wants to talk to us, and banks you're talking about, including the post office, has men employees. So when we go down to bank, men look at us, and we don't want to be looked at, because selling our bodies may be a profession, but we also have dignity. We would like to be treated as such when we are in our other spheres, like we go for investments, or we take our children to school, or we go marketing. We don't want people to look at us. That's then I asked them that if I make this post office a complete women run, everybody, right from the multitasking person, that's the Group D employee, to the postmaster, to everybody, if it's all women, will you come and bank with us? They said, if everybody is a woman, we'll be more comfortable. So that's where the challenges started. Because when I tried posting women said, oh, madam, our husbands do not let us come here, because the moment they hear that we've been posted in Kamatipura, they say, that taboo again. They don't want us to work in Kamatipura. It took me a lot of education, myself going every day, sitting there, talking to both my staff, postal women, as well as the sex workers, about why it is necessary that we together, it's a sisterhood, why women can't stand by each other. to take this ahead. And of course, I had no idea where this project would go. Then Aadhaar cards. I realized that their children cannot have Aadhaar cards because they have home deliveries. So there is no date of birth certificate, father's name unknown, mothers themselves did not have Aadhaar cards. So you had this whole chunk of population, children, who were born in India, who can't prove citizenship. And Aadhaar is not a proof of citizenship, but you can't open their card because they had nothing, no documentation. Then I had this series of talks with Aadhaar authorities saying, what do we do about these children? You can't say you can't give cards because Aadhaar today is linked to many other things. We opened a special counter, when I say it's a computerized, of course, counter, which the UIDI authorities had to open, especially for children who can't show anything for an Aadhaar card. And the local corporator can sign as a guardian. So then we had so many Aadhaar cards coming up. This project grew. It grew. Then we sent girls from our post offices to teach them computers. I have this project with, everybody's blessings has grown. We've got 10 girls of age 18 to 25 employed as secretaries and stenos and receptionists, even with some doctors, because we asked these doctors not to declare what their mothers did, because these were girls who were educated, class 12 pass, and we got them computer training, English speaking courses. I teach them English and finishing, how to dress up, what to wear, what not to wear. Because first day in class, when these girls came to me in my post office, they all wore red lipstick, big jhumkes, because for them, they have grown up seeing their mothers. This for them is attractive. So, getting them to a different mindset. So they are employed elsewhere. The boys are also employed. We got them local employment through appeals. Nothing. I have not taken anything from government expenditure at all, neither taken private donations. Yes, what did we work on? On the goodwill of the neighborhood post office. So when I showed you the letterbox, and when you think that does not exist anymore, whoever goes to a post office, there is so much of goodwill that we have generated in these 165 years of operations that when we appeal, people listen. So what stops us? Personal involvement. Everybody who asks you that, your doctors, what else do you do? Just look around. There is so much you can do because you are the educated class. You are the enlightened class. You are the few who got to be here listening to seminars, giving seminars, hearing each other. So I won't say if I could do because I had a team I could dream of. And Devi will tell you, I've always been an errant person. I've always wanted to do more than what the square box defines. We all want magical solutions to our problems, but we do not believe in magic. You are the magic yourself. Thank you.
Mama.
So if you want any, if you want any questions or you want.
Swati, that was very inspiring and I'm very impressed, and it must have been some journey. What were the obstructions or obstacles which you and your family must have faced, the most difficult ones?
Listen to me, at age 50, I think your family has learned that no matter what obstacles they have, I'm not going to listen. I'm too old to listen. I don't care shit. That's number one. Number two, yes. My husband also asked me that you're every day in Kamatipura. What the hell are you doing there? So, and that's what my colleagues asked. Why are you bothered? Because, classically a bureaucrat, because I'm from the civil services, like I said, you don't really need to get out of your office. I have 3 personal staff, 3 stenographers who take my notes. I have a whole battery of people to stop people from meeting me. So that's how we work. Civil servants, you have to take appointments and you have to ask whether we are free. So getting out of office, my own colleagues did not understand that why the hell did I need to even get out and go and dirty my hands in Kamatipura? So that was the challenge number 1, that no support from colleagues and, no support. You have to be directed. But more than me, I don't care shit. It was my lady staff whom I posted in Kamatipura, which I really felt challenging because I kept on posting people and they kept on running away on medical leave, child care leave. They said, we can't go. Hamare sasur nahi allow karte hain. My sass does not allow. My husband does not allow. When I posted the older staff, she said, my son does not allow. My bahu says, chi. Ab wo area mein jati ho roz. Because the truth is, when you enter Kamatipura, you have people peddling their bodies. So you meet people. Today I've become friends. For me, it does not look, it doesn't. Earlier when I entered, even I felt awkward because remember, it's not only those women, it's their customers. So when you enter, their customers are also going to look at you and your body. I have been heckled by pimps twice. When I was walking down, 2 pimps asked me as to what is my rate. So, you have to tell yourself that this is not important. It is the journey. If you have a helping hand, I won't say helping hand because I grew as a person myself. So I have been helped. If I have helped them, they have helped me. So, I think it is basically that you got to do what you got to do. And you got to try out permutations, combinations. Right now, there's an art therapy class. We have taken 25 paintings and we are auctioning these paintings. We've got a charity ball with a diplomat community in Mumbai by 10th of June. And the money so raised will be credited to their individual savings bank account that I have opened. So these are children from age 7 to age 25. Their paintings will be auctioned and the, consul generals and the ambassadors will be coming on a ball charity event. So again, like I told you, no money spent, no middlemen, it's direct transfer of funds. So you have to be sure as to, you don't carry agendas. Please don't carry agendas. When I started this, I didn't even know where this was going. It so happens that the press and media have got to like it. Not my own doing. It was word to mouth publicity. NGOs have joined in. I've got now 4 NGOs, pitching in. I've got an NGO taking these kids to meet John Abraham and Tiger Shroff. So, these are things that feel good.
Yeah, so essentially you have to go by your heart, carry no agenda, work from your heart, and there will be obstacles. But as long as you are convinced about your purpose, your selflessness, I think that should carry you forward.
Yeah. No agenda. The moment you have agenda, you have, you've negated your purpose and it shows. Because, press and media are not fools today. It shows. They do research about you. They do research about your background. They see whether you are just coming in an AC car and just do a photo op or you actually work, for them. So people watch you. You have to be intent in your purpose. My purpose, of course, like I said, that most of these women, 90% of these women are Bengalis. I'm a Bengali, part Bengali myself. Things clicked. I thank Lord Jagannath that I could be in a position to, be a, what do I say? Some light in their lives.
So I can ask one
Wonderful,
question.
Swati. That's wonderful.
Ask one question.
Please.
That's wonderful. Yeah, so can we have the next session? Swati, thanks a lot. Thanks a ton.
My pleasure. Thank you, all of you. I heard about your glaucomas, didn't understand, but I'm sure you have a long day ahead. Thank you very much.
Thanks a ton. Yeah, so can Dr. Pragya take over for the second session? And can we have the postgraduates and the judges ready?
Yes, thank you so much, Devi. Welcome to the next session. It's the Vitro Retinal session. And we have, am I audible? Okay.
Yes.
We have with us our judges, Dr. Sandhya Makija, Dr. G.N. Rao, and Dr. Sanghamitra Kanungo. I'm sharing the screen. Can you see my screen?
No.
No. Dipun? Dipun, kita screen share हो My screen is seen?
No, no, no.
No. Huh?
Maybe you can just talk about them.
Yeah.
So the screen is, we can
Okay.
just maybe introduce them and we can have the postgraduate.
Okay.
If the screen can be shared, fine. Otherwise, we can have the postgraduate. Yeah, so it's
Yes.
Yes.
Can you see now? Yes. We have with us Dr. Sandhya Makija. Her graduation is from Lady Hardinge Medical College and post-graduation is from Guru Nanak Eye Hospital, Mamsi, and DNB and SRship from Eye Care, Noida, fellowship from Retina Foundation, and she is a fellow of International Council of Ophthalmology University Hospital, Belgium, and she was also a fellow of New York Eye Hospital. She's a practicing consultant at Sant Parmanand Hospital and Shyamlal Eye Hospital. She has various recognitions and achievements. She has papers, presentations, and talks in Delhi, state and national conferences since last 15 years. She is the head of the Delhi chapter of Women's Ophthalmic Society. She is a faculty of DOS, URSI, IIRSI, and other conferences and meets since last 10 years. She is a panelist in various national and international meets. She is the examiner, thesis assessor in various DNB ophthalmological programs in the state. We have our judge, Dr. G.N. Rao. The name itself is sufficient. He is a founder, director, Vision Care Center for Retina, Bhubaneswar. His undergraduation is from MKCG Medical College, Berhampur, and post-graduation is from AIMS, Delhi. Fellowship from Arvind Eye Institute, Madurai. We have with us Dr. Sanghamitra Kanungo. He is a postgraduate from VSS Medical College, Burla. Fellowship in IOL and anterior segment microsurgery from JPM Rotary Eye Hospital and Research Institute, Cuttack. Fellowship in Retina Vitro Service at Arvind Eye Hospital, Madurai. Short-term UVA fellowship from Sankar Netralaya, Chennai. She was an observer in Retina department in Bascom Palmer Eye Institute, Florida. Working as a consultant Vitro Retinal Service and UVA service in Car Vision Eye Hospital from 2011, contributed multiple free papers and posters in various national and international conferences, guest speaker in state and national society. She has 16 publications in index peer-reviewed journals, including in IJO and retinal cases and reports, ophthalmic surgery, lasers, imaging. And she got the best paper award in state chapter in 2018. So welcome all the judges. We have with us 7 presenters, Dr. Isha, Dr. Tarun, Dr. Shan, Dr. Soumya Shri, Dr. Japesh, Dr. Priyambada, and Dr. Kalpana in this order. To start with Dr. Isha. I have to.
Stop share.
Yes, yes.
Stop share.
Dipun. Stop sharing. Stop sharing. Dr. Isha, please share your screen. Is she there, Dr. Isha?
Yes, she's
Yes, ma'am. Yes, ma'am. There.
Yes. Please share your screen.
Is it visible?
Yes.
Am I audible?
Yes, you're audible, Dr. Isha. Please carry on.
Good morning, all. My name is Dr. Isha Nirgudkar, and I'll be presenting a case moderated by Dr. Jyoti Prakash. Patient particulars, it was a 58-year-old male contractor by occupation hailing from Madhupatna, Cuttack, with chief complaints of diminution of vision since past 2 weeks in the left eye. History of presenting illness, patient had diminution of vision in left eye since past 2 months, which was gradually progressive, for which he had not consulted anywhere. It aggravated suddenly in the past 2 weeks. It was painless in nature. No history of redness, no history of any trauma, no history of any past surgery. The past medical history, patient is a non-diabetic and a non-hypertensive. There's no other systemic history. Patient is a non-alcoholic and a non-smoker. Coming to ocular examination, head posture normal, facial symmetry maintained, extraocular movements full and free. In the right eye, the uncorrected visual acuity was 6/18 for distance and N12 for near, which was getting corrected to 6/6 for distance with plus 1.25 diopter sphere and N6 for near with plus 2.50 diopter sphere. In the left eye, the visual acuity was 1/60, where no improvement with correction. The color vision was 21 and 21 on Ishihara's isochromatic color vision chart, and it could not be assessed in the left eye. The intraocular pressure with Goldman's applanation tonometry in the right eye was 14 millimeters of mercury, and in the left eye was 12 millimeters of mercury at 9:10 a.m. The pupil was regular and reactive in both eyes. Coming to the posterior segment examination, it was done using a 90D slit lamp biomicroscopy and a 20D lens indirect ophthalmoscopy. In the right eye, the media was clear. Optic disc was medium in size. The cup disc ratio was 0.3. The blood vessels were within normal limits with dichotomous branching from the optic disc. Macula was foveal reflex was present. The fundus was within normal limits. In the left eye, the media was hazy. Optic disc was medium with a cup disc ratio of 0.3. Blood vessels were normal with dichotomous branching from the optic disc. In the macula, there was a single raised reddish-orange subretinal nodule with patchy hemorrhage. In the fundus, there was massive subretinal hemorrhage almost occupying the posterior fold, approximately 2.5 disc diopter radius. So as you can see in the right eye, it was within normal limits, no features. In the left eye, there was a single reddish-orange nodule in the macula with massive subretinal hemorrhage extending till the temporal arcade superior and inferiorly, nasally till the temporal border of the disc. So summarizing my case, a 58-year-old male came with chief complaints of sudden onset diminution of vision in the left eye since the past 2 weeks. Patient had painless diminution of vision since 2 months, which aggravated in the past 2 weeks. On fundus examination, left eye showed a single raised reddish-orange subretinal nodule with massive subretinal hemorrhage. My provisional diagnosis being left eye polypoidal choroidal vasculopathy, probably of idiopathic origin. Thank you. My differential diagnoses are choroidal neovascular membrane, retinal angiomatosis proliferation, PEHCR, traumatic submacular hemorrhage, and choroidal ductal hemorrhage.
Questions by judges? Dr. Sandhya, Dr. G.N. Rao, and Dr. Sanghamitra.
Why did you give your first diagnosis as IPCAV? I mean, why not just a CNVM as first diagnosis?
CNVM, yes, it can be a differential diagnosis, but there was no associated drusen feature. There was no absence of drusen, and in the fellow eye also, there were no ARMD features or any geographic atrophy or reticular pseudodrusen features.
But normally you will not see drusenoid lesions with so much of subretinal hemorrhage and exudations.
Ma'am, there were no exudations.
Common diagnosis first, you know. Understanding you proceed with your investigations and everything. I mean, you have to keep common diagnosis first, always first.
Yes.
There's no harm in keeping first diagnosis as CNVM.
Yes.
And when you were describing your fundus examination, you said media is hazy in the left eye. So why was it hazy?
And there was associated anterior segment examination was normal, but in the left eye there was associated a nucleus sclerosis cataract. So that's why we
what?
Nucleus sclerosis cataract in the left eye, which I because of the time constraint I couldn't mention the anterior segment finding, but it was nucleus sclerosis cataract in the left eye.
Here, I mean, what I could see.
Sorry,
your fundus picture is pretty clear. I mean, I don't think it's hazy at all.
Yes. It's not very good.
Any other questions from anyone else?
Yeah. Why do you say that it is IPCV? What other tests would you like to carry out to prove that your diagnosis is IPCV?
Firstly, ma'am, I would like to do optical coherence tomography, OCT. On OCT, if it's an IPCV, we will find PED, pigment epithelial detachment, particularly thumb sign, along with a double thumb sign showing subretinal fluid. Also, we can do FFA, but in this case, because of the massive subretinal hemorrhage, there will be blocked fluorescence, so we will not be able to see the choroidal vasculature. So for that, we can do an ICGA, which is indocyanine angiography, which is the investigation of choice for PCV. So in that, we can see polypoid features of the choroidal vasculature and branching vascular network. Even OCT angiography will show the branching vascular network, but the polyp will be mostly highlighted in the ICG.
You've done those investigations? Do you have pictures?
Yes, ma'am. I have done actually OCT was done in this patient. FFA was not done because it was because of the massive subretinal hemorrhage. So we wanted the hemorrhage to come down. That's why we haven't done the FFA. And ICG is not available in our institute, so we have not done ICG.
So what do you think is the diagnostic test for you in this case?
The diagnostic test is actually ICGA, but since because of non-availability, we have done an OCT in this case.
So that is what I was basically wanting to tell you, that unless you do an ECG,
ICG will not confirm PCV. Yes,
although the most probable diagnosis looks IPCV, but you have to have an ICG.
Differential, yes.
Octa did you do? No.
Octa is not available again. ICG and Octa are not.
So how did you go ahead and manage?
Ma'am, for this massive subretinal hemorrhage, actually, what we did was there was aflibercept anti-VEGF injection. Aflibercept was given on a treat and extend basis. So 3 monthly per month for 3 months, and then followed by treat and extend basis. So this was 1 month post the first injection of Eylea, aflibercept. The vision improved to 6/60, which was 1/60 in the pre-op visit. Then after the second injection of Eylea, the vision improved to 6/24. And as you can see, the PED is also reduced along with the subretinal fluid. So yeah, you have to give the third injection and see the...
Okay, can we go to the next speaker? Dr. Isha, please stop sharing. Next speaker is Dr. Tarun.
Yes, ma'am. Am I audible, ma'am?
Yeah, you are audible.
Your screen.
Yes, Dr. Tarun, start your presentation.
Yes, ma'am.
No, your screen is not visible.
Okay, ma'am.
Dr. Shan, you also keep your presentations ready.
Go to the share screen.
Is my screen visible, ma'am?
No, not visible.
Maybe the next speaker can speak.
Yes, can we go to the next speaker, Dr. Shan? Meanwhile, Dr. Tarun, you keep your slides ready if there is a technical problem.
Shall I share?
Yeah, Dr. San, you can go ahead. Your presenting time is 4 minutes.
My slide is visible, ma'am?
Yeah, your slide is visible.
Yes. Good morning, all. Myself, Dr. Sammu Sudram. My mentor is Dr. Prejasni Misra from Department of Ophthalmology, AIMS, Bhubaneswar. A 25-year-old female presented with complaints of 2 months of headache, diminution of vision in both eyes. History of presenting illness, patient was apparently all right 2 months back. Then she developed a headache which was diffuse, dull aching, no aggravating and relieving factors, not associated with the fever, vomiting or neurological symptoms. Headache was associated with gradual diminution of vision in both eyes. No history of redness of eyes, any discharge, photophobia, colored halos, or pain on ocular movements, head trauma, or any surgery. And in past history, no history of similar illness in the past. Then there is a past history of difficulty in night vision. Then patient is also diagnosed as of gestational hypertension during pregnancy, which is 5 years before. Then discontinued medication after delivery. There is no other history of other systemic illnesses. Then no significant personal and family history. There is a personal intake of analgesics. And on gender determination, patient is conscious, well-oriented, but uncooperative, severe headache, then average body build and no pallor, icterus, cyanosis, clubbing, edema. On vitals examination, blood pressure showing 210 by 130 millimeter of mercury is recorded. On ocular examination, visual acuity is showing on right eye 660 with pinhole improving to 636, and left eye 660, no improvement on pinhole. Intraocular pressure is in right eye 12 millimeter of mercury and left eye it's 13. And color vision testing, it is 25 by 25 in both eyes, and facial symmetry, orbit, eyelid and eyelashes are grossly normal. Extraocular movements are full in all cardinal gaze, and pupil is sluggishly reacting to light, and swinging flashlight showing no evidence, no RAPD is elicited. On slit lamp examination, anterior segment findings are within normal limits in cross. Then on fundoscopy, right eye showing edematous hyperemic disc with blood margins and cottonwool spots and sphincter hemorrhages on the confined to the peripapillary area. Then macula showing foveal reflex, dull foveal reflex with a few hard exudates and blood vessels of mild dilatation and tortuous veins, and arterial attenuation more prominently in the nasal side, and periphery showing Yeltsin spots are present here. Then bony spicules are present. And fundus examination of left eye showing edematous disc with blood margins and mild temporal pallor and cottonwool spots and few hemorrhages, and macula showing dull foveal reflex and few hard exudates. Blood vessels showing mild dilatation and tortuous of veins, and arterial attenuation in the arterial attenuation, and periphery showing Yeltsin spots and bony spicules, and infranasally there is a retinal pigment hyperplasia is present. So the provisional diagnosis of malignant hypertensive retinopathy and choroidopathy with retinitis pigmentosa has been elicited, and the differential diagnosis of after all the clinical examination and differential diagnosis of bilateral optic neuritis and neuroretinitis or papilledema and bilateral non-arteritic anterior ischemic optic neuropathy has been elicited. Thank you.
Questions from the judges?
Was there any serious detachments in both eyes?
Sir, on fundus examination, grossly it's not shows. On further investigation, sir, on undergoing OCT imaging, it shows there is serious subretinal fluid, serious detachment in the macular area.
Because You saw the actually the fundus picture was showing like there was some retinal elevations were there. Although the choroidopathy is there, that means serious detachment will be there, part of the.
Yes, sir.
So how it is significant? What is the significance of malignant hypertensive retinopathy?
Sir. On history, there is a past history of gestational hypertension, and then after that, the patient has discontinued medication also after delivery. Then there is no regular blood checkup also, sir. Regular.
No. What I'm asking is, what is the systemic significance of this? Why you say malignant hypertension? What is the reason? How it is important systematically?
Yes, sir. Blood pressure is around 210 by 130 millimeter of mercury, sir. On fundus examination, it is showing arterial attenuation and venular dilatation, sir, with bilateral disc edema having splinter.
That is the reason. What is the importance of this? Finding this malignant hypertension, what you will keep in your brain, what you will want to the patient, how it will be serious regarding systemic illness.
Sir,
is there any significance, either hypertensive retinopathy, accelerated or malignant, when you are finding something, you have to keep that there is the patient a chance of actually going into coma or vital organs like
yes,
kidney
sir,
will be affected.
Sir, other investigation has to be done further, sir. Cardiological workup, ECG, then 2D echo, sir. Then for central nervous system, MRI, brain or CT scan has to be done, so that neurological part has to be evaluated, sir, to look for any space occupying lesion is there or not. Then, sir, ultrasound abdomen to rule out any adrenal hyperplasia, to look for any pheochromocytoma. Then, sir, blood investigations of renal function test to look for urea, creatinine, to rule out any renal parenchymal diseases or renal vascular diseases. So other systemic evaluation has to be done according to that patient mortality or morbidity can be explained this, sir.
Okay, Dr. Shanmugam, in which other conditions would you find cortical spots?
Ma'am, conditions are ischemic retinal fiber layer, ischemic, and diabetic retinopathy, ma'am. Then in papilledema also, ma'am. In long-standing papilledema, we can see cortical spots confined to the peripapillary areas, ma'am. Then leukemic retinopathies, ma'am, then sickle cell retinopathies, ma'am. Then hemoglobinopathies, we can look for these are the places we can find out cortical spots. Mainly ischemic retinal fiber layer ischemia.
How will you manage?
Patient is advised for strict glycemic control, and further investigations I want to make, ma'am. In that routine blood investigations, ma'am. Then ultrasound.
Go ahead with management.
OCT to look for any macular edema, ma'am. Then fundus fluorescein angiography to look for to confirm the choroidopathy features, ma'am. Then patient is advised for strict blood pressure control. Then
you really need OCT here for this patient?
Yes, ma'am.
You've just said just to complete your list.
Yes, ma'am. OCT is done, ma'am. Then macular subretinal fluid has been found for this patient.
That increase is expected. You have to be judicial and you have to know that what patient, what investigation. It's not okay, OCT you have, so you do OCT in every case. It's not necessary.
Okay, can we go to the next speaker? Dr. Tarun, are you ready with your presentation? Or should we go to Dr. Soumya Sri? Hello, Dr. Tarun.
Dr. Soumya can present.
Okay, Dr. Soumya, please go ahead.
Is Dr. Soumya there?
Dr. Soumya?
Yes, ma'am. Just a minute, ma'am.
Yes. Share your screen.
Then maybe the next PG also can be ready.
Yes. Dr. Japesh. The next speaker is Dr. Japesh. Please be ready.
Hello.
Yes,
Hello?
you are audible, Soumya.
Yes, ma'am. Ma'am, my slide is visible.
Yes, your slide is visible.
Thank you. Good morning to all. Respected ma'am. Today I am going to present a presentation of a case. Now coming to my case, my patient is of 13 years Hindu female, presented to our OPD with chief complaint of diminution of vision in right eye followed by left eye for 20 days, multiple scaly hyperpigmented rashes with erythematous rim over the face, eyelid and scalp for 2 months, low grade fever, body ache, joint pain for 2 months. Now coming to present illness, patient was apparently already 2 months back. To start with, she developed low-grade fever with myalgia followed by arthralgia, for which she was admitted to pediatric department and was diagnosed as a case of systemic lupus erythematosus, for which she was undergoing treatment there. She has undergone blood transfusion with packed RBC while undergoing pediatric department. She then complained of diminution of vision in right eye followed by left eye for 20 days, for which she was referred to our ophthalmologist OPD and was evaluated. Now coming to past history, there was no similar illness in the past. There was no history of tuberculosis or any other malignancy, no history of diabetes mellitus, hypertension or other cardiovascular diseases. There was no history of any other systemic illness. There was no history of any drug intake. Coming to personal history, the patient is of thin body build. She is on average mixed Indian diet with normal bowel and bladder habits. Now coming to general examination, the patient is conscious, sick looking and well oriented to time, place and persons. Now coming to vitals, pulse was 120 beats per minute, blood pressure was 108 by 60 millimeter of mercury, temperature was 100 degree Fahrenheit, respiratory rate was 20 per minute. The pallor was present in the patient. There was no icterus, cyanosis, clubbing, edema or lymphadenopathy. On systemic examination, on chest, bilateral vesicular breath sound was present. On cardiovascular system examination, S1, S2 was normal. There was no murmur. For abdominal examination, was soft and non-tender abdomen without any splenomegaly, and CNS also was within normal limit. Now coming to visual acuity in right eye was hand movement positive with pinhole. There was no improvement. In left eye, visual acuity was safe 1 meter with pinhole. There was also no improvement. IOP in right eye 12 millimeter of mercury and left eye 14 millimeter of mercury by NCT. In LPA was patent in both eyes. Now coming to anterior segment examination, ocular adenixa, that is, it shows erythematous rashes present over upper eyelid with periorbital edema present in both eyes. Conjunctiva was white and cornea was clear in both eyes. Antechamber content depth, iris color pattern was also normal in both the eyes. Pupil, in right eye there was RAPD and in left eye pupil was round regular and reacting to light. Lens was clear in both the eyes. Now coming to fundoscopic examination, ocular media was clear in both the eyes. Optic disc shows the shape and size of the optic disc was distorted in both the eyes. Margin was blurred, splinter hemorrhage present over the disc. Color was hyperemic in both the eyes. Cup disc ratio was obliterated in both the eyes. Vessels, it shows arterial attenuation with perivascular sheathing with dilated and tortuous veins in both the eyes. Macula, the FR was absent in both the eyes. General fundus, it shows multiple dark blood and flame-shaped hemorrhages in all quadrants. This is the fundoscopic picture of the right eye and left eye. It here shows the shape size of the optic disc was distorted with blurred margin with hyperemic optic disc with splinter hemorrhages present, and it shows dilated and tortuous vessels with perivascular sheathings present. Now coming to investigations, the CBC shows normocytic normochromic anemia with thrombocytopenia. The hemoglobin was 6.2 gram per deciliter. ESR was raised 170 millimeter per hour.
Time is over, Dr. Soumya. And go for the
provisional diagnosis was retinal vasculitis associated with papillitis in a patient of systemic lupus. Thank you.
why was there? You said that there was fever, no? The temperature
sir,
100. See,
yes, sir. There is
patient
low
was
grade
sick
fever.
even. No.
Yes, sir. Sick.
So in that case, actually, suppose your findings are only anyway. The findings are, you said that this is anemic patient, and all those features you showed, but rod spots are there in the fundus. Pale-centered hemorrhages are there. No.
Yes, sir.
Pale-centered hemorrhages are there. Although that is
Cancer
characteristic of anemia, then in a sick patient, fever, what will be the differential diagnosis for others? Anything is there?
Sir, actually, retinal vasculitis of SLE was diagnosed in that patient. So it may be of SLE retinal vasculitis.
Okay. Anything?
Sir, other infectious causes of retinal vasculitis can be of TB vasculitis can be there, or viral vasculitis, which is hepatitis vasculitis, not parasitic vasculitis like toxoplasma vasculitis, or secondary to neurological diseases like multiple sclerosis, and other secondary to malignancy like acute leukemia, lymphoma, retinal vasculitis can also there, and systemic inflammatory diseases like secondary to SLE, sarcoidosis, Eisner's granulomatosis, polyarteritis nodosa, then rheumatoid arthritis, HLA-B27 associated uveitis can be there, sir. And idiopathic, isolated ocular disease, retinal vasculitis can be also there, like frosted branch vasculitis, even idiopathic retinal vasculitis, aneurysm, and neuroretinitis can be there.
Dr. Soumya, if you just look at the fundus, what would you think without looking at other systemic parameters?
So, optic disc margin was blurred, then hyperemic optic disc, safe size was restricted. So, papillitis with retinal vasculitis, the arterial narrowing of arteriole is there, and with dilated and tortuous vein, with perivascular seeping is also present. So, papillitis with retinal vasculitis.
Did you have any neovascularization also?
There was no neovascularization. It is in the stage of active inflammation.
What investigations you did?
Actually, the blood parameters like CBC is done. Then to rule out other causes, infectious causes, we have done Montauk's test to rule out TB, then chest X-ray PAVU to rule out tuberculosis, sarcoidosis, then to rule out viral retinal vasculitis, we have done HIV, HBsAg test, then we have done to rule out SLE, to diagnose SLE, we have done antinuclear antibody test, CBC, which with hemoglobin, then ESR was raised, and then serum urea creatinine, LFT, RFT test were also done.
How did you manage? What treatment you did?
Actually, now it is serious progression. So mostly oral, mostly high dose corticosteroids, IV or oral corticosteroids should be given in this patient, followed by other SLE related treatment. Can also we give cyclophosphamide or other non-steroidal biological treatments like azathioprine, anti-malarial drugs like hydroxychloroquine, etc.
Did you do angiography?
Actually, no, ma'am. The first patient was very sick looking, so at that time we haven't done it.
See, in such cases,
Sorry. Please carry on. Yeah, please carry on, ma'am. I'm sorry.
So, can we go to the?
Yeah, angiography is interesting because you need to see, are there any leakages? What state is it still active vasculitis, and on the basis of that, you would actually your treatment would base on that actually.
Yes, ma'am. Yes, ma'am.
Can we go to the next speaker?
Thank you, ma'am.
Yes.
Good afternoon, ma'am.
Yes.
Ma'am, is my screen visible, ma'am? Yes.
Not yet.
Can Priyambada try? Yes, ma'am. Good morning, ma'am. Yeah, please share. Okay, Japes is
Japes. Okay.
Yes, ma'am. Good afternoon, everyone. I'm Dr. Japesh Thareja, PG resident second year from IMS and SUM Hospital, under the mentorship of Dr. Pradeep Kumar Panigrahi, Associate Professor, Department of Ophthalmology. I am presenting a case of 55-year-old female, resident of Bhubaneswar, housewife by profession, who presented to us with the chief complaints of sudden painless diminution of vision of right eye for 10 days. Patient was apparently asymptomatic 10 days ago when she developed diminution of vision in right eye, sudden in onset, not associated with pain, redness, or discharge. There was no history of trauma to the eye or any recent intraocular surgery. Patient is a known case of diabetes and hypertension for past 15 years and under treatment. There is no history of asthma, GIT disorders, or any allergies. No history of similar episodes in the past and no history of any drug allergies. Personal history and family history was not significant. On general physical examination, patient was conscious, cooperative, and well-oriented to time, place, and person. Vitals were within normal limit. On local examination, head posture was normal, facial symmetry was maintained, eyelid and nexa were within normal limit for both the eyes. Ocular motility was full and adequate in all direction of gaze for both the eyes. On anterior segment examination, best corrected visual acuity for right eye was hand movement positive and left eye was 6, 6 and 6. Rest of the anterior segment was within normal limit. IOP as measured with applanation tonometry for right eye was 15 and left eye was 17, that is within normal limits. On fundus examination for right eye, the media was hazy due to blood in the vitreous, possibly suggestive of vitreous hemorrhage, and there was no view of the rest of the fundus. For left eye, the media was clear. Optic disc size, shape, and color was normal with a cup disc ratio of 0.3:1. Neuroretinal rim was healthy. Blood vessels were within normal limits. Macular area showed few hard exudates, and on peripheral fundus examination, multiple dot and plot hemorrhages were seen. Thus, a provisional diagnosis of 55-year-old female with right eye vitreous hemorrhage and left eye moderate NPDR was made. Thank you.
So, Dr. Japesh, why do you think there would have been a vitreous hemorrhage?
Ma'am, according to the clinical history and presentation, ma'am, most probable cause may be, ma'am, posterior vitreous detachment along with avulsion of pre-retinal blood vessels, ma'am. Or, ma'am, it may be due to proliferative diabetic retinopathy also, ma'am.
So, what other investigations would you like to do?
Ma'am, we can do a B-scan examination for the right eye as fundus was not visible, ma'am. For any other associated retinal breaks or and we can also identify PVD on B-scan, ma'am.
You want to
Left
see
eye.
it?
Left eye.
For left eye, yes, sir. Sir, OCT examination can be done to rule out macular edema, sir. And blood sugar investigations and should be done for the patient as patient is a known case of diabetes, sir.
No, OCT you said macular edema for which eye?
Left eye, ma'am.
Left eye. So for right
Anything
eye,
else? No angiogram?
का जो question था, to do ultrasound B-scan for right eye.
Sorry, ma'am.
Ma'am had asked you this question, no? Why would you like to do ultrasound B-scan for the right eye?
Yes, ma'am. Ma'am, as the fundus is not visible, ma'am, to identify any association.
Do you want to see in right eye?
Ma'am, any associated retinal breaks or PVD, ma'am.
Break you want to see?
Sorry,
Can
ma'am?
you see a break? Are breaks visible in?
Sorry, ma'am. Retinal detachment, ma'am.
Really? I mean, anything more specific? What do you want to see? I mean, in ultrasound scan, you know the patient is diabetic vitreous hemorrhage.
Yes, ma'am. Ma'am, fibrovascular proliferations can be seen, ma'am.
If there's any traction, is there any tractional detachment, you know?
Yes, ma'am.
To look for traction. And firstly, you want to look whether the vitreous hemorrhage is relatively fresh or is it like an old or organized vitreous hemorrhage?
Yes, ma'am. That we can differentiate on B scan, ma'am.
Why are these things important?
Ma'am, it will help us in the management of the vitreous hemorrhage, ma'am. Ma'am, if it is a fresh vitreous hemorrhage, like in this case of unknown etiology, ma'am, we have to observe for 3 to 7 days, ma'am, and ask the patient to bed rest for the patient with head end up, ma'am, raised head end, so that the vitreous hemorrhage can settle, ma'am. Then after 3 to 7 days, if we are able to see the view of the fundus, and then we can find out the pathology and plan accordingly, ma'am.
So what will be your plan?
Ma'am, for this patient, we will first observe for 3 to 7 days, ma'am. Ma'am, then if vitreous hemorrhage does not resolve, ma'am, then we have to go for pars plana vitrectomy. Yes, ma'am.
Straight away past plana vitrectomy. Or would you like?
Ma'am,
Would you like to go in for surgery or would you like to do something else?
ma'am, anti-VEGFs can be given.
What did you do for the other eye? Did you do
Ma'am,
anything?
other eyes, ma'am, according to the fundus picture, it is classified as moderate NPDR. So, and there is no visual impairment, ma'am. So we will observe the other eye and ask the patient for strict glycemic control, ma'am.
Observe like what? Did you do anything for the other eye? Just observation.
Yes, ma'am, as vision was not impaired, ma'am.
One eye has got vitreous hemorrhage. The other eye, you're saying moderate NPDR.
Yes, ma'am.
So what else should you do for the other eye?
The most important thing you should do for the left eye now, in this case.
Ma'am, we have...
After 1 week, patient becomes blind in both eyes.
Ma'am, we have to...
You for that. You didn't do anything.
No, ma'am, we have to do complete retinal examination for the left eye.
Anything else?
Anything else you want to do?
For left eye, ma'am?
Yes. First eye, the right eye is having a vitreous hemorrhage.
Yes,
the other
ma'am.
eye, you're saying it's moderate only.
Yes,
Are you
ma'am.
missing anything in the left eye?
Ma'am, some NV.
So what would you do?
Ma'am, laser photocoagulation for the NV, ma'am.
No, but you don't know whether there is NV on.
Ma'am, yes, ma'am. No NV was found, ma'am.
What would you do to establish your diagnosis?
Ma'am, FFA, ma'am.
Oh, yes.
Can we go to the next speaker?
Thank you,
Dr.
ma'am.
Priyambada, are you ready with your presentation?
Yes, ma'am.
You can share your screen.
Ma'am, am I audible, ma'am?
Yes, you are audible. Your screen is seen.
Yes, ma'am. Good afternoon, everyone. Esteemed judges and panelists, I am Dr. Priyambada Subudhi from SCB Medical College, Cuttack, and today I am going to present my case here. So, it's an 11-year-old male child, a student from Keonjhar, presented to our ophthalmology OPD on 29th of April 2022 with the chief complaint of gradual diminution of vision in left eye for 3 months. The patient was apparently all right 3 months back when he noticed a painless diminution of vision in left eye, which was gradual in onset and progressive in nature. There was no history of any discharge from the eye, no history of redness, watering, or photophobia. There was no history of fever, no history of injury to the eye or head, and the patient did not complain of any color halos or floaters. The past history, family history, and personal history or treatment history was not significant. The birth history was uneventful. Coming to the general examination, the patient was conscious, alert, cooperative, and well-oriented to time, place, and person. He was of average body build and adequately nourished. He was afebrile, There were no palpable lymph nodes or glands present. All other systemic examinations were within normal limit. The BP was recorded to be 110 upon 70 millimeter of mercury, and pulse rate was 78 per minute, and respiratory rate being 20 per minute. Coming to the ocular examination, the head was erect, face bilaterally symmetrical, eyebrows at the same level. The interpalpebral fissure was normal, gaze was orthophoric, extraocular movements were free and full in all directions. The orbital margins were well felt all around. Lids and adnexa of both eyes were within normal limit. Proclus was negative for both eyes. Coming to the visual acuity, in the right eye, the visual acuity was 6/6, while in left eye, it was hand movement positive and not improving with glass. The color vision in right eye was normal, while in left eye, it could not be assessed due to poor visual acuity. The intraocular pressure in right eye was 16 millimeter of mercury, and in left eye, it was 14 millimeter of mercury. The pupil in right eye was single central, round, regular, reacting to light, while in left eye, it was single central, but RAPD of grade 3 was elicited on swinging flashlight test, and a leukochorea was observed. Coming to the slit lamp biomicroscopy, the right eye slit lamp examination was unremarkable, while in left eye was unremarkable. There was no iris neovascularization. There was no, the lens was in position and transparent. Coming to the indirect ophthalmoscopic evaluation, the right eye showed a normal fundus study, while the left eye, the midriasis was good, media was clear, optic disc was within normal limit, cup disc ratio being 0.3:1, AVR being 2:3. In the macula, the foveal reflex was absent. There were golden yellow exudates present in the macula. In the periphery, we could see vascular sheathing present and dot hemorrhages in the supranasal and supratemporal quadrant. Neovascularization was seen in the supranasal quadrant. Exudates were present all over the central retina, and there was a bullous exudative retinal detachment noted inferiorly. This is a colored fundus photograph of the right eye, and along with the fundus diagram showing a normal fundus study. This is a color fundus photograph of the left eye along with the fundus diagram showing massive exudates and sheathing of vascular sheathing, dot hemorrhages in the supranasal and supratemporal quadrant, neovascularization in the supranasal quadrant, and an exudative retinal detachment inferiorly. So my provisional diagnosis is Coats disease of the left eye. Thank you.
How old is the patient?
Sir, 11-year-old.
Male or female?
11-year-old male child, sir.
So do you think it's common in young boys?
Sir, yes, sir. Coats disease has a predilection for male children, and mean age of presentation being 10 years.
A similar picture happen in adults?
Sir, so we can think about sir, diabetic retinopathy.
Did you do fluorescein angiography?
Sir? No, sir. Actually, we had advised the patient for an FFA, but the patient lost the follow-up.
How will you manage?
Sir, in this case, since there is a massive exudates present and there is an exudative retinal detachment also present, so I think we can go for an intravitreal triamcinolone acetonide along with laser photocoagulation.
Where you will do laser?
Sir, in the peripheral, we can laser photocoagulation of the aneurysmal vessels.
Prognosis?
The prognosis is not very good in this case.
The patient will ask, you will do so much of treatment to me, whether I will get the vision or not. What you will tell?
The prognosis is variable in case of Coats disease. So we can explain it is seen that after triamcinolone, intravitreal triamcinolone acetate, the exudates have been resolved in some cases, but the vision may improve, or we can explain to the patient that the patient will be having a comfortable eye with cosmesis.
Where is the pathology here?
Sir, ma'am?
Where is the pathology here?
Ma'am, in Coats is usually telangiectatic vessels which are leaky, and due to which there is exudation and deposition of lipid in the subretinal deposition of lipids, which leads to decrease in visual acuity.
Mhm. So if you do timely treatment is done, the prognosis is not so bad actually.
Yes, ma'am. If in the earlier stages, like stage 1 or stage 2 cases, when there is only telangiectation, exudation, laser photoablation of the aneurysmal vessels or cryotherapy also have a good prognosis.
And what are the any systemic associations?
Ma'am, it is seen sometimes it course is associated with Turner's syndrome, and sometimes it's course-like presentation is also seen as facioscapular humoral dystrophy.
Was there anything, any associated vitritis or anything here?
No, ma'am. Actually, in the fundus photograph, my fundus photograph of the left eye is not very clear because the patient was not fixating properly. But on indirect ophthalmoscopic examination, the media was quite clear.
So, can we proceed to the next case? If no questions.
Can we go to the next speaker? I think Dr. Tarun is ready.
Yes, ma'am. I'm ready.
You can go ahead with your presentation, Dr. Tarun.
Yes. Is my screen visible, ma'am?
Yeah, it's visible.
Good morning, everyone. Today I'm going to give a case presentation on vitreous hemorrhage. To start with, a 25 years Hindu male RSP employee came with chief complaints of acute painless unilateral loss of vision and floaters in right eye. History of presenting complaint. Patient was asymptomatic 2 days back. Suddenly he noticed painless unilateral loss of vision along with floaters in his right eye in early morning. Visual loss was not progressive in nature. No history of any chronic systemic disease like diabetes, hypertension, etc. No history of bleeding disorders. No history of ocular inflammation, trauma, or ocular surgery. No relevant drug history like anticoagulants. Family history, his mother had tuberculosis 4 years back. General examination, all were within normal limits. Local examination, visual acuity of right eye was 636, left eye 69. Best corrected visual acuity of right eye was 636, left eye 69. On local examination, both right eye and left eye lid agnexa were in normal limits. Conjunctiva normal, cornea clear, anterior chamber quite normal in depth, pupil single, central normal in size, pupillary light reflex both direct and indirect was present. Lens of both eye was clear. Media of right eye was hazy. Optic disc was seen hazily as if headlight in the fog. Blood vessel visible in temporal quadrant, which was tortuous. Exudate and sheathing around the vessel was present. Periphery hazily seen due to vitreous hemorrhage. Foveal reflex not appreciated. Fundus of left eye was normal. This is the fundus diagram of the right eye showing vitreous hemorrhage in nasal quadrant. There is a seeding of retinal vein with hard exudates. My provisional diagnosis is right eye venous vitreous hemorrhage due to Eales disease. Left eye was normal. Thank you.
In one of your findings, you have stated that it was headlight in a fog.
Yes, ma'am.
Which disease is very typical in your description?
In posterior uveitis, toxoplasmosis.
Some other disease has got this typical feature where we describe that headlight in a fog.
Ma'am, it is seen in posterior uveitis.
So again, my question, what investigations you would like to do?
Ma'am, first we take our visual acuity, then we do slit lamp by microscopy, dilated fundoscopy, B scan.
Louder, can you please be a little louder? I hardly hear you.
Ma'am, we do dilated fundoscopy. We do regular follow-up with the B scan.
Treatment, how will you treat?
We keep the patient head elevated so that the hemorrhage could gravitate down. We give vitamin C and do regular follow-up for to see whether it is resolving or not hemorrhage. If there is any neovascularization, then we can give anti-VEGF, or we can do PRP, pan retinal photocoagulation. And if it does not resolve for 6 months, then we can do vitrectomy or spinal vitrectomy.
So what are the investigations did you do?
Ma'am, we did B scan, ma'am.
Do you have pictures? Do you have any pictures of your investigations?
Sorry, ma'am. I do not have it.
You said the mother was diagnosed to have tuberculosis, right?
Yes, ma'am. 4 years back.
So did you investigate for the patient also?
Yes, ma'am. We sent for Montox and chest X-ray, PA view.
Sometimes this Montox and all this is not quite relevant. So what other investigations to establish tuberculosis should you be doing?
I'm a chest X-ray, ma'am.
HRCT chest is more diagnostic than chest X-ray.
This case, can I say?
Yes, ma'am. Please go ahead.
In this case, we have, by doing investigation, there is raised C-reactive protein. And on fundus finding, there was vein was tortuous and seething and exudate present. So we thought it is a case of Ills disease. And we started systemic steroid. And patient improved from vision 6/36, it came to 6/9. So there is a great improvement. And patient is a young adult and male and sudden onset. So we thought it is a case of Ills disease.
Was there any fundus photograph?
Yes, fundus photograph there, but he has not given here.
So that is the
Yes, that
hint.
is the
If
case.
nothing
Yeah.
is there, how can one?
Actually, they told us you have to present only clinical finding. So we restricted our fundus photograph. As it is a clinical examination, so we restricted the all. We did
Fundus photograph was allowed, madam. Anterior
Yes,
segment
yes.
and fundus photograph was allowed.
Yes, he has not given. Okay, ne?
Any comments from other panelists or anyone else? Or can we go to the next speaker, Dr. Kalpana? Dr. Kalpana, are you here? Dr. Kalpana, please share your screen. Is she there? She is there, yes.
Please respond. Kalpana, are you there?
The last speaker of this session is Dr. Kalpana. Dr. Kalpana? she's not responding.
Just give me a minute, I'll call her. In the meantime, everybody can keep the video mode on for a screenshot. So are you there? So you're not responding. You're not responding. Start sharing. What happened? What happened? I can't understand. I can't get it. I think she's having some network issue. She'll reconnect in 2 seconds. So in the meantime, the panelists can put in a word. Dr. Santosh.
Can I speak?
Yes, yes.
Yes, sir.
It's not academic related, but I want to say that it's going on very well. Great work, Devi. After a long time, we have many PGs speaking in a forum and learning a lot. Thanks to all the judges and panelists. I think great. It's a very good learning experience for the postgraduate students. You know, they get this opportunity to present in so many in front of so many people watching them. So it gives them confidence. Even if it is a simple case presentation, I think the students should not get scared or get refrained. You know, it's a joy of presenting. It's an experience of presenting, which is more important. And I think the students have done beautiful, very nice presentations. I'm very happy to see their presentations. They've drawn very nice fundus pictures as I saw in these presentations. So, except for there was a little confusion probably in the photographs showing and all those things, but overall the presentations were very nice.
It's not easy being questioned in front of an open forum, because even in an examination hall, it's you and the examiner.
Yeah.
Here it's an open forum, but I think it's healthy learning. I think it's there for everyone to learn.
And team
They'll be meeting most of you across the board in the exams.
I must congratulate Team Odisha, especially Dr. Devi, who's taken the lead and done a very beautiful program and put
everybody's support.
Whole team has put so much of effort. Very nice program it has come up. Congratulations.
Hello, thank you. Yeah, Kalpana, yes, please.
Yes, I'm so sorry for the disturbance, ma'am. May I start, ma'am?
Dr. Kalpana, are you ready?
Yes, ma'am. Ji, ma'am. Good afternoon, everyone. Today I'm going to do a case presentation. A 51 years old female, a homemaker from Kazi Bazar, Cuttack, presented to the OPD with chief complaints of gradual painless diminution of vision in both eyes since 1 year and sudden worsening of vision in right eye since past 1 month. Coming to the history of presenting illness, the patient was apparently normal 1 year back when she started developing gradual painless diminution of vision in both eyes with sudden worsening of vision in right eye since past 1 month. The history also had complaints of floaters in the left eye since past 4 months. There was no history of pain in different cases, no history of watering, redness, photophobia, colored halos, scotoma, or any discharge from the eye. There was no history of any fever or injury to the head and eyes. Coming to the past history, the patient is a known case of type 2 diabetes mellitus for past 25 years, for which she is taking oral hypoglycemic agents and insulin on a regular basis. There is no history of any other systemic illness or ocular trauma or surgery in the past. The family history, personal history, and treatment history of the patient was found to be insignificant. On performing the general examination, it was found to be normal and the vitals were found to be stable. On ocular examination, the head was erect, the face was bilaterally symmetrical, the eyebrows at same level and IPF normal. The extraocular movements were free and full in all the cases, and orbital margins were well filled all around in both the eyes. Coming to the slit lamp examination, the eyelids, eyelashes, and the skin over lacrimal sac area was found to be within normal limit, and Rho+ was negative in both the eyes. On anterior segment evaluation, the conjunctiva, cornea, and anterior chamber were within normal limit. The iris was normal, there was no neovascularization, and the pupil was single central, round, regular, reacting to light. Coming to the vision and intraocular pressure assessment, in the right eye, the fixation was central. The visual acuity for distant was 6/60, which improved with pinhole to 6/36, and the near vision was N18. The PR, color vision, and IOP in the right eye was within normal limit. Coming to the left eye, the fixation again was central. The visual acuity for distant was CFCR, which did not improve with the pinhole, and the near vision was less than N36. The PR and the IOP was within normal limit for left eye, and the color vision could not be assessed. Now coming to the posterior segment evaluation, in the fundoscopic finding, there was mydriasis was a good in the right eye, and the media was hazy due to the reddish floating vitreous opacity in the temporal and the inferior quadrant, and translucent floating vitreous opacity over the disc and the macula, that is suggestive of the vitreous hemorrhage. Then the disc margins were faintly visible in the right eye, and the rest of the details was not visible due to the haze. Coming to the left eye, mydriasis was again good, and the media was hazy due to the grayish-white floating vitreous opacity, and the disc showed mild pallor. The size, shape, and the margin of the disc was within normal limit. The CDR ratio was 0.3:1, and the vessels were slightly distorted, with the AVR remaining maintained as 2:3. There was some vitreoretinal traction membranes above and below the disc that were indicative of the tractional retinal detachment. And over the macula, there was some fibrovascular proliferative membrane that was indicative of the epiretinal membrane with a pseudo hole over it. In the periphery, there were few dot block hemorrhages and exudations in the superior and inferior quadrant. This is the fundus diagram of right and left eye. My provisional diagnosis is high risk PDR with vitreous hemorrhage in right eye and high risk PDR with fibrovascular traction bands in the left eye. Thank you.
Once the five, sorry, sir.
Sorry, sir.
Yes.
No, you can carry on.
Once the fibrovascular proliferation is developed, still you say high risk.
Sorry, sir, you're not audible.
Once
sir.
the fibrovascular proliferations have developed and caused tractional retinal detachments or traction bands have formed, still you call it as high risk.
1 second, sir. Actually, I can't hear you clearly, sir.
No, that is what actually I'm asking, because you noted it as fibrovascular proliferations with traction bands and vitreous hemorrhage developed already, full, but still you are naming it as high risk PDR.
Yes, sir, actually,
Then what
there
is
are
the
features
risk?
of...
Then what is the risk? Already it has developed the risk. What is the risk then?
Yes, sir.
What is the stage it should be? Sir is indirectly asking.
So it should be actually, it is showing features of the advanced diabetic eye disease.
So what would you do for this patient now?
Ma'am, in the right eye, because of the vitreous hemorrhage, we will proceed with the posterior pars plana vitrectomy. Since already in the left eye, there is so severe changes are seen and the prognosis may be poor. So for the right eye, we will proceed as early as possible so that then there is no chances, less chances of formation of the fibrovascular stance, which may cause again traction over the retina.
So before proceeding for pars plana vitrectomy, what all you will do?
Yes, ma'am.
Before you proceed for pars plana vitrectomy, what all you will do?
Ma'am, for the right eye, I will do P-scan ultrasonography to rule out any retinal detachment. And for the left eye, ma'am, we can do OCT.
Of the macula, since there is a presence of fibrovascular membrane over the macula. There might be appearance of a hyperreflectile membrane over it. And there is, we can also do FFA in the left eye to see any capillary non-perfusion areas and any neovascularization, so that we can plan for PRP after the.
Yes, be there. No?
Advanced case. So why do you want to do FFA?
Now, so as to plan the location of the pan-retinal lamp photocoagulation precisely.
So in this case, do you think pan-retinal PRP is going to benefit?
Ma'am, in the left eye, ma'am, there is very less chances of prognosis. But ma'am, in the right eye, if there is no retinal detachment, then there might be chances of better prognosis in the right eye.
Okay, in right eye, if there's no retinal detachment, then you say there are better chances. But what if there's a detachment in the right eye? Will you proceed or no?
Yes, ma'am. Then we will, along with the pars plana vitrectomy after the expiration of vitreous hemorrhage, we can do fluid gas exchange along with the silicone oil implantation, ma'am.
If needed, yeah. So in left eye also, you will plan, ultimately you will plan for a pars plana vitrectomy, and you would like to peel out all the membranes and fractions. Maybe the patient, the patient might improve. And before proceeding for pars plana vitrectomy, you would like to give anti-VEGFs also. Before you proceed for pars plana vitrectomy, you would like to give anti-VEGF.
Yes, ma'am. We can give anti-VEGF so that the vascular component of the fibrovascular stand is reduced, so that there will be less bleeding during the intraoperatively. And the vascular component, when it reduces, it will also cause relaxation of the traction. So there is less chances to the injury over retina during the procedure. So we can give an anti-VEGF, and then we can follow by a PPV and the removal of the tractional retinal bands, along with the endolaser or silicone oil implantation if needed.
And meanwhile, you have to look after the systemic status also. You have to do a thorough systemic work. With this kind of retinopathy, obviously advanced nephropathy is also expected in such patients. So you have to tell the patient accordingly that, the whole workup needs to be done, systemic workup.
In this situation, we will do CBC, ESR, the blood profile, and blood sugar levels will be examined along with the RFT for the serum creatinine to rule any nephropathy. The blood pressure should all be examined because hypertension and hyperlipidemia, they may cause progression for the progression of the diabetic retinopathy.
All the presentations are over, I think. Any comments from the panelists?
Wonderful presentations. I think Dr. Kalki, you can stop sharing your screen.
Yeah. Dr. Kalpana, you can stop sharing your screen.
You could post me your score sheets.
Yes.
Thank you so much, Dr. Sandhya, Dr. GN, and Dr. Sanghamitra. Be there, be tuned in. We are not over yet.
Oh.
I think the postgraduates can leave after the screenshot is taken.
Me?
Next
Shall I
we
go?
have the, yeah, you can. I think next we have Dr. Aarti's talk, but I think she has gone out of network coverage. So I had put in a word to her. Maybe I'll continue with my talk, and then she will log in whenever she can. Is that okay?
Yes.
So I'll be talking about resistant to resistance. and everything went off. I cannot see my screen. Can you see my screen?
We can see.
I cannot see my
Keep the
screen.
presentation open and then
No,
share your
that is there,
screen.
but something happened and suddenly got minimized everything.
You can leave the meeting and rejoin again. Your screen is visible now, but you're not audible.
I'm not audible.
Okay. Yeah, now you're audible.
I'm audible?
Yeah, yeah, yeah.
Yeah, so we'll be getting a little academic here. Resistant to resistance. How to choose the right antibiotic in ocular infection. Yeah. So how to choose the right antibiotic in ocular infection? So as we know, antibiotic resistance is a global concern. There's little doubt that we have a global pandemic of antimicrobial resistant or microorganisms. Regional variations do exist. The overall trend has impacted on individual cases, society, the economics of managing infection, and our approach to the empirical use of antimicrobial compounds for both inpatient and on an outpatient basis. So what do we understand by antimicrobial susceptibility? As we all know, that we are very much aware of MIC, that is the lowest drug concentration that inhibits growth of an organisms. So MIC testing has been used since decades as the gold standard for determining the efficacy of antimicrobial agent. Antimicrobial resistance, as indicated by high MIC, is usually predictive of an unfavorable outcome. Higher MICs usually indicate a greater likelihood of clinical failure. Now, there are certain new measurements of in vitro antimicrobial susceptibility. So before that, we must understand what is a mutant prevention concentration. So it's a novel in vitro measurement, that is MPC. It takes into account the probability of mutant subpopulations that may escape the regular MIC of antimicrobial agents. So MPC drug concentration is typically higher than the MIC. So the MPC of a drug can never be lower than the MIC. If a certain mutant population of the organism being studied escapes the MIC, then that is amplified and then it is again tested so that you get a concentration of that drug which will prevent the mutation. So these mutant organisms from growing. So that is the MPC. This suggests that prevention of growth of mutant subpopulations from high density bacterial inoculate requires high drug concentrations. So let us understand this concept of MPC very well. It is defined as the lowest drug concentration required to block the growth of the least susceptible cell present in high density bacterial populations. So suppose we take a population of bacteria and going to test it for antibiotic susceptibility. We have something called MIC, that is the minimum inhibitory concentration. With this, most of the bacteria would be either killed or the growth would be inhibited. But there will be a certain subpopulation of a mutant subpopulation which will escape this MIC. So we have to again test this subpopulation of mutant population that has escaped, and then that concentration of the drug that will inhibit the growth or block the growth of this subpopulation is called the MPC. So MPC testing applies to microorganisms considered susceptible to the drug by MIC. Suppose a drug is not susceptible to MIC, there is no point testing it for MPC. If it does not, if minimum inhibitory concentration, it is resistant, there's no point testing that drug for MPC. So only when it is susceptible to a certain antibiotic, only then we are discussing MICs and MPCs. So the potential value of MIC and MPC. So let us go to this figure. So in a billion population of this bacteria, there will be 2 in 1 billion, out of which in a healthy immune system, most will have a potential clearance. The MIC will work on most except 2 in a billion. So this 2 will be the mutant subpopulation. Then this 2 will again increase the bacterial growth. So MPC looks into that concentration of the drug that will inhibit this 2 subpopulation of the bacteria. So how is it tested? There is selective amplification of the resistant mutants, that is MPC. Then we test the drug for MPC. Then there is direct clearance of infection or control of infection clearance via immune system help. So during infection, both susceptible cells and first step resistant mutants are present. Dosing at the level of the MPC would result in either direct clearance of infection via lytic drug action or control of the infection facilitation clearance via the immune system. Either it will directly kill that subpopulation or it facilitate the immune system to get rid of that subpopulation. So mutant selection window. So this is the mutant selection window. That which cannot be killed by MIC, but that which can be blocked by the MPC. So this is the mutant selection window. So MPC inhibits, more than MPC, it will inhibit the susceptible as well as the mutant growth. Less than MIC, neither mutant nor susceptible growth will be inhibited. Within the MSW, susceptible cells are likely inhibited, but mutant cells will not be inhibited. So when we raise the concentration above the MPC, then this subpopulation of mutant cells will be inhibited. So MIC and MPC measurements need to be considered along with pharmacokinetic and pharmacodynamic data. The action of antimicrobial agents are clearly affected by PK and PD parameters. 3 PK-PD relationships have been established and applied to various classes of antimicrobial compounds. So what are some of the ophthalmic drugs used in infection? So aminoglycosides, they inhibit protein synthesis by binding to the 30S ribosomal subunit. The fluoroquinolones inhibit DNA gyrase, topoisomerase 2 and topoisomerase 4. Then the microlides bind to the 50S ribosomal subunit of susceptible microorganisms and interfere with microbial protein synthesis. Then polymyxin B increases the permeability of the bacterial cell membrane by interacting with the phospholipid components of the membrane, and trimethoprim interferes with the folate synthesis. So choice of antibiotics, what do we call an ideal antibiotic? So an ideal anti-infective agent should have the following features. It should be broad spectrum, bactericidal. It should have a good tissue penetration, low toxicity. It should act rapidly. The third fluoroquinolones predominantly bind to either DNA gyrase or topoisomerase 4, whereas the fourth generation fluoroquinolones exhibit dual mechanism by binding both to DNA gyrase and topoisomerase 4. So this is very important in understanding why it is difficult to develop resistance to fourth generation fluoroquinolones. Parameters for selecting a good anti-infective is the susceptibility, the broad spectrum coverage, the potency, the kill rate, the toxicity, and the compliance. So here are some of the studies on MICS of fluoroquinolones. Fourth generation fluoroquinolones are far more active in vitro than third generation fluoroquinolones. So some of the bacterial isolates may be resistant to the third generation, but it is difficult to develop resistance against the fourth generation. When we compare the in vitro susceptibilities of gram-positive cocci isolated from ocular infections, gatifloxacin showed a 26% higher susceptibility compared to moxifloxacin. Gatifloxacin also showed a higher susceptibility towards third generation fluoroquinolone resistant pathogens compared to moxifloxacin. So coming to the spectrum of bacterial keratitis at a tertiary eye care center, this was done in Trichy, Tamil Nadu. So still staph epidermidis remains the highest, that is 64%, followed by Streptococcus, Pseudomonas, Bacillus, Acinetobacter, and Aeromonas. So in vitro susceptibility of bacterial keratitis isolates, the most common gram-positive organisms are more susceptible towards gatifloxacin. Both gram-positive and gram-negative ocular isolates are more susceptible towards gatifloxacin than moxifloxacin. Now coming to the sensitivity and resistance to the drug. So how do the bacteria develop resistance? So fluoroquinolone resistance can develop either through mutations in the DNA gyrase or the topoisomerase. But if a drug acts at both these levels, then it is difficult to develop. It's unusual for a bacteria to develop resistance at both the sides. That is why it's difficult to develop resistance against the fourth generation fluoroquinolones. So expression of multi-drug resistant membrane-associated efflux pumps, which actively pump the antibiotic out of the cell. That is one mechanism, and the other mechanism is the resistance at these two sites. So this is what I was talking about. Staph aureus is the most prevalent organism everywhere, and most of these isolates are susceptible to gatifloxacin. So gatifloxacin versus moxifloxacin, it has a lower MIC as compared to moxi against Pseudomonas. So gatifloxacin has a high sensitivity and the least resistance. So it shows that it is more efficacious than fluoroquinolones, than other fluoroquinolones. So this is again a corroboration of the same study. Everywhere we see that Gati has a better organisms have a better sensitivity against gatifloxacin. So now coming to MPC. The MIC and the MPC values of gatifloxacin are consistently lower than for moxifloxacin for Haemophilus influenza. That also for staph epidermidis from in vitro. These are all in vitro studies. So comparative MIC and MPC of gatifloxacin and other compounds against gram-positive ocular pathogens. Here we see that Gati's MIC is the least, and Gati's MPC is also the least, 0.063. As it goes higher up, like it is lesser for levofloxacin and ofloxacin, and the least for ciprofloxacin. The sensitivity. So the MPC and the MIC are least for Gati, and it is higher up for the other three drugs. Same here for Pseudomonas aeruginosa. And coming to the ocular penetration. Intraocular penetration after topical instillation. Most fluoroquinolones exhibit concentration dependent killing. So MIC is the least concentration that will inhibit or kill, and any concentration that we achieve above MIC will act better. So they exhibit concentration dependent killing. So as we increase the concentration of a drug beyond MIC, it shows increased bactericidal activity. It occupies more number of binding sites on the bacteria, and it shows more effective treatment outcome. The fluoroquinolones are concentration dependent bactericidal agents. So the AUC by MIC is very important. That is the area of the curve. When we are testing the sensitivity and the susceptibility, we get such curves. So the area under this curve divided by MIC is very important. So more the area, the better the efficacy. So higher AUC by MIC of gatifloxacin as compared to moxifloxacin shows it has improved efficacy as compared to moxi. And when we talk about intraocular penetration after topical instillation, the concentration of GATI in aqueous humor was significantly higher than those of moxifloxacin at 3-point-hour sample, that is after first instillation. So this is using collagen shields pre-soaked in oversaturated solutions of the antibiotic. So after application of this collagen shield, 3.4 hours after that, a sample was taken and GATI showed higher concentration in the aqueous humor as compared to the moxi. Now coming to ocular tolerability and retention. So these are studies to compare ocular tolerability of commercially available ophthalmic solutions of GATI 0.3% with BAC and moxi 0.5% without BAC. We know that moxi comes without BAK. So GATI 0.3% significantly better tolerated than moxifloxacin 0.5%. I have an individual observation here in most of my patients that when you blind them to the kind of drop that is being used, most of them would complain of a sharp stinging sensation when you're instilling a drop of moxi as compared to GATI. This has been the case, universal finding in all my cases. Then coming to retentionability, significant difference between the ranges of the cultured conjunctival CFU after antibiotic administration in both study groups of GATI versus moxi was observed. GATI was found to reduce conjunctival bacterial flora more significantly than moxifloxacin. It shows better retention, more supporting its use for prophylaxis before extraocular and refractive surgeries. Then speed of action. In comparing the kill rates, gatifloxacin eradicated bacteria that commonly cause ocular infections considerably faster than moxifloxacin, 0.5%. So this is GATI 0.3% versus moxi 0.5%. This was also seen in 46 consecutive patients that required penetrating keratoplasty. At every follow-up, there were more eyes with complete graft reepithelialization in the GATI group as compared to moxi group. And post-operative use of GATI in corneal transplant patients may allow the early stages of corneal graft reepithelialization to proceed more quickly than does treatment with moxifloxacin. Then what is the role of BAK? Like, there are certain Lee sites to the use of BAK, but what is the role of BAK in this processing formulations? A study was undertaken in BAC. Can somebody mute? Yeah, a study was undertaken with just plain BAC, then gatifloxacin 0.3% containing BAC or a BAC-free moxifloxacin. So what was seen is the kill time was fastest The kill time was fastest in gatifloxacin with back. I think Dr. Aarti is on the phone. Can somebody call her? I'll connect you. I'm just taking the call. Hi, Dr. Aarti. Yeah, I'm in the middle of my talk, so can I just connect you after that? Sorry about that. So, what we see, the highest kill rate and the lowest kill time is for Gatti with back as compared to plain back or moxie. So this shows that back has a synergistic action with gatifloxacin. So the MPC of gatifloxacin back and gatifloxacin with back is different. So the presence of back at concentrations to 7 micrograms to 10 micrograms per milliliter lowered the MPC of gatifloxacin against MRSI. So there is a definite synergistic role of back in these formulations. It also shows enhanced killing of MRSA strains with gatifloxacin as compared to plain back or plain gatifloxacin. So this is again a correlation of that. So back enhances the in vivo antimicrobial efficacy of gatifloxacin. The dosing regimen. Gatifloxacin 0.5% administered twice daily for the treatment of acute bacterial conjunctivitis. So in total, they were randomized into 2 phase 3 studies. 1433 patients received at least 1 dose of the study drug. Microbiological cure was higher in gatifloxacin 0.5% than vehicle at days 4 and 6. The combined MIC for gatifloxacin 0.5% was 2 mg per ml for gram positive and gram negative organisms. So this is again gatifloxacin 0.5%. So let's not confuse with the 0.3 and a 0.5%. When we are talking about a twice daily dosing in just bacterial conjunctivitis, this is twice daily dosing of gatifloxacin 0.5%, not the 0.3%. So in summary, the antibiotic resistance has become a global concern. The lower MIC of a drug indicates higher potency of the antibiotic, and lower MPC ensures delay in the rate at which quinolone resistance would occur. Highest sensitivity and lowest resistance indicates that the gram-positive isolates showed lowest resistance to gatifloxacin. Gati also has least MIC and MPC values as compared to other agents, indicating higher potency of the antibiotic and slower rate of resistance. Gatifloxacin is significantly better tolerated, has good ocular penetration, and has faster speed of action than moxifloxacin. Gatifloxacin ophthalmic solution is a 4th generation fluoroquinolone with back preservative and broad spectrum activity and had low resistance profile. Thank you. So any questions on that? I think the concept that we must understand that there is something beyond MIC. As students, we were taught only MIC, but now I think students must also understand the concept of MPC. So because there is emergence of more mutants, more resistant mutants. So just using a drug based on MIC may not be sufficient. The mutant population might escape and grow. So we need to study the MPC of drugs also. And testing a drug for MPC is not as simple as testing a drug for MIC, because MIC is usually done in all lab facilities. But MPC, you need to actually amplify the mutant subpopulation, and then the MPC is tested on this amplified mutant subpopulation. So MPC testing is not as simple as MIC testing. So can we proceed to the next talk? Any comments from any of the panelists or judges?
Can I give a, sorry.
Yes, sir. Yes, sir.
As you said, the effectivity is high because getiploxacin is, I think, not used such rampantly. You know, moxifloxacin is available over the counter at the cheapest drug.
Drug misuse is another cause for emergence of mutant population. But once we have the mutant population, what do we do about them?
Sparingly used. Getiploxacin is sparingly used.
At a point, it was given up.
Yeah.
And it doesn't have any oral preparation also.
Yes.
No, it has.
It has, but it is not common.
But it is not used.
Not used. Even Gatti or even Moxie, it is not. Oral preparation is not used as much.
Both Moxie and Getty has oral preparation, but it is not used.
It's not.
So, Devi, but for you, we can use Getty, not Moxie.
I have never stopped using Getty. I think I'm the only one who has continued with Getty.
I used to prepare Getty process with loteprednol.
Yeah. I'm
Very
also
good result.
very fond of Getty and Lutagate.
Yes.
Welcome, Dr. Aarti.
Favor of Moxie.
Hi, Aishwarya. I'm so sorry for dropping connection. Can you hear me?
Yes, we can.
Okay. See, I was seeing the quality of. Yeah, you can just start my talk. Yes.
Just a minute.
आधा घंटा दिख रहा है इसके ऊपर इतना टाइम लग गया
We will be having next. We'll be having our talk. Dr. Aarti addressing everybody on WOS and its way forward. She's the state head of WOS Haryana. Right now, she's the unit head of Fortis. I'm also an associate and senior consultant with Site Avenue. Previously, she has worked in Max Hospital and as MD in PGI Hospital. She is a prolific femto laser, cataract, refractive, and squint surgeon. Besides being the state head of Haryana, she is the member executive committee and outreach programs, women ophthalmology worldwide, and she is instrumental for the conception of Rotary Eye Hospital care in Delhi a few years back. She is an entrepreneur, business head, and partner in standalone chain of hospitals like CFS and Fortis Escorts, Delhi. So over to you, Dr. Aarti. Welcome.
So much, Devi. Can you hear me? Or my sound is cracking? Can you hear me?
Yes, I can hear you. But yeah, I have to get up.
Thank you so much for having me in this scientific session of yours, which I was seeing was very, very high grade presentations by all the residents. I welcome all the delegates, the panel, the esteemed judges, and I wanted to speak upon the Women in Ophthalmology Society. What is it all about? And it's been, Devi, can you put my presentation?
Yes.
So we are all a part of this organization. And when it started with just a handful of us, I cannot see the slides.
Can you see?
No, I cannot. Can you hear me?
Yes, I can hear you. I don't know.
Yeah, just share, go on to share, and perhaps then it will be able to open up.
Yeah, okay. Is it visible now?
Yes, it is. Let's start from the first slide. Yeah. So I wanted to talk about was that we are all today doing a whole lot of different wings of this organization. As you know, it is multifaceted society. So when it really started at the inception, was conceptualized by Dr. Mohita, of course. Change the slide, Devi. So we were just a handful of us, and now, of course, there are about 200 plus members, and of course, it has gone global to women in ophthalmology worldwide. Can you shift the slide, Devi? Can you go to the next one? So when it came in the being, everybody said, why do we need women in a particular society? So it wasn't to do with gender bias. It was basically to have a society with certain unique, specific ways of working and having different kind of group. So now members chapter is one of the society. Next, can we have the next slide? So as they say, it's the giver's game. Your greatness is not what you have, it's what you give. So it wasn't to do with our growth. It was to do with the growth of all the stages of development of particularly women professionals. Next. So in a society, it's vision and mission, which makes different programs and how it can help our residents. We've seen the state chapters are doing wonderfully well. Likewise, we have these programs like Mentor-Mentee, which of course is talking about how you reach success, how you use your skill, how it is satisfying learning, it's one-on-one. And we've had these mentor-mentee relationships over the lot of webinars we've done over the time. Next. Along with this mentor-mentee, a very popular program, WAS believes in being different. 25 activities all over India. I think none of the societies so far have been able to reach every corner of the country, and of course globally as well. Next. So when we've seen it all, that we are all part of this society in a very eminent society. There have been breakfast meetings, there have been state chapter openings. Recently, I think Calcutta had one. It started with its state chapter. Next. We've had annual conferences. We've had 4. We are going to have one more coming in, which will be along with the aliens of the worldwide WOW society as well. So we have collaborated with women in ophthalmology worldwide. So we will have representatives from Pakistan, Bangladesh, Canada, America, Singapore. So we're soon meeting up in Jan to be decided. Next. The past things done that we had competitive academic sessions, we had a Shark Tank of innovations, we had a research session, leadership, medical legal aspects, mentor-mentee sessions, women health and yoga session. So our conference is different. Being women, it has to be different. So we talk about being healthy mentally and physically. Next. So we had these particular sessions where we started our day on a conference day with a yoga session, and thereafter they were live streams. About you, and if you are proactive, you can make the best. Now, from various I searched
I think we are losing her connectivity. So I think we have built up a galaxy of mentors. We have through these mentor-mentee sessions who are available who are just a call away from any mentor and any mentee across the country.
Can you hear me?
Yeah, I think you went. Yeah, now we can.
Okay. Yeah. Thanks for catching up on my slides. Okay, next. Let's have the next. Yes, definitely we have mentors And it's again, as I said, it is not about gender. It is men, women, both in the society. So when we had these residence program, so it wasn't to do with the residents being only women presenting. It could be men as well. Our mentors to each resident are also very, very qualified and very well placed senior surgeons. So it's an amalgam and a galaxy of very great thinking minds, and having to train and fine tune our residents in such particular programs. Do not miss a single element or any which way. The upgradation goes clinically also along with these presentations for a doctor to become a true professional. We've had these programs of rendezvous. We've had these programs of leadership. We had very recently, after the demise of our colleague Archana, Dr. Archana. So we sat and we thought that how can we contribute in such kind of situations. Yeah, rendezvous I just spoke about. That here what we did was that how the success story of each professional could be, shared, and that would inspire other women as well. And it was very interesting. It was a model where question and answers were asked that what is the formula to success. Next. Likewise, we did a leadership program where we had stories narrated by all our very eminent surgeons. And that, of course, is going to inspire. Our purpose is to inspire people, the professionals from the day they enter this field. So that was very inspiring program, very well appreciated. Next. So as we of course we've been felicitating. We've had international award-winning presentations. This is Life Beyond Ophthalmology. We're all aware of. It runs very well on the Facebook. So these are the kind of programs which we've been doing. Next. The competitive sessions are all doing their best. I think I'm going to have the Haryana chapter coming in 12th June. So I want everybody here to log in as well. And I know Devi's done a wonderful job in this particular chapter. Next. So Project Archana by WAS, I think this was a very unique thought by our seniors. And we were in impromptu. We just made this, webinar done almost the same the next evening after the demise of this doctor. And we talked about that you're not alone in this profession. If you have issues, if there are angry patients, if there's violence around, if there's a mob thing, next, you have your phone call away. You should have, your nearest police informed. And in any case, any of the senior colleagues can be called. So it's not about a gynecologist. It can be any doctor. Harassment and these kind of victimization of doctors are happening and can happen. So we are all one, and the society is also thinking on those lines of making professionals legally stable. Next. Next. So as I spoke about the mental health, the emergency helpline, so the doctor doesn't have to be harassed. She doesn't, because a woman can actually feel alone, and can still have collaboration with many kind of, associations. And one is very flabbergasted when such a situation happens. So you can actually do a phone call, or, you can have your security around. So we talked about, we really discussed how we can make our OPD safe from these experiences. Next. We will go to the next. Yes. So WAS awards were also given this year, and it was a very well attended program, and felicitating our women ophthalmologists, so women who will, that's the heads. Slide. On to the next. Just very the and research. There were many activities done. There were formal trainings given to all the Women Ophthalmological Society members. There's a DRDO, Government Association also, where a woman who's had a gap in her profession can get a job as a research scholar. And this kind of advent happened in WAS only. And research opportunities projects with government tie-up are in the pipeline, and it's going to be more work done on it. There is already set up at the Noida where the research has begun, and we've had few trials in the courses being done. Webinar sessions have been doing since 2018. They've been on with the top-notch research professionals. Dr. Rohit Chetty has been a great help in this particular program. Next. So we are going to move on with a lot of research in the coming time. And we look forward to many women who are particularly interested in research to come forward and be a part of this program. Next. Now we can go to the next slide.
I think this is the end of this. I think this is the end of it.
So if you can go on.
I think this is the end of
it. All right. So my purpose was to just introduce WAS and BOW, and also make a note that this society is emerging. It is very, very progressive. And maybe I think you can carry on with your resident program. Wanted to say that we look for the way.
Thank you so much, Dr. Aarti.
For you.
Yeah, thank you so much.
Advantage of. Thank you, Devi.
Yeah, so this was just a message to all the youngsters how much of opportunities WAS offers. So, and there'll be more coming because every year we are coming up with new ideas and better outreach, we are reaching out to more and more people. So please do become members. Be convinced about becoming a member. So don't become member by force. Yeah, so Dr. Sharmishta, can you take up the next session, please?
Yes, thank you, Devi. At the outset, I welcome thank you, Dr. Aarti, for such a nice speech that you have given. Just just a minute. I'm not able to share my the judges. I'll just get back. Devi, just a minute. I'll just get back.
We can see.
For this, I'm so sorry for this. So we have with us ophthalmic doyens of Odisha. We have Professor Dr. BNR Subudhi sir with us. I can say hope I'm audible.
Yes, you are.
Hello.
Yes, yes.
Yeah.
Yes.
Sir, I can say he breathes ophthalmology from morning 5 a.m. to 10 p.m. daily. We see him early in the morning and late in the night also. He has with him a strong team of all of us, and along with us, he has his son and daughter-in-law to support, and he has a very futuristic approach towards ophthalmology. He has a hospital, Ruby Eye Hospital. So I'll speak in very short because we are already running time. He is Dr. Ashok Nanda sir. He's the director in Cora Vision Eye Hospital, Bhubaneswar, and he has done his fellowship in comprehensive ophthalmology from LV Prasad Eye Institute, Hyderabad. And he is also a doyen and a low profile person, but we know how much he does for ophthalmology in Odisha. Then another judge amongst us is Dr. Rita Das, who is a senior consultant in ophthalmology. She's doing cataract and glaucoma, and she's got over 25 years of experience in various hospitals, multi-specialty hospitals also like Apollo Hospital, and she has been working also in JPM Eye Hospital, Cuttack. So with all of you on board, please, we welcome you, and we can go over to the speakers. Hello.
Yeah, there's one point I wanted to add, that all three of them are established DNB and MS examiners.
Yes, yes. They have got all the teaching experience also. And we can go over to the speakers. Please start sharing your slide, Dr. Bhumija. And Dr. Amit, please be the next to speak. Please start sharing your slides, Dr. Bhumija.
Very good afternoon to all. Am I audible and my slides are visible?
Yes.
Yes.
Very good afternoon to all the judges and the panelists. I'm Dr. Bhumija Bhatt from Department of Ophthalmology, AIIMS Bhubaneswar, and I'm presenting my case under the mentorship of Dr. Sucheta Parija. So my patient is a 14-year-old female who's a resident of Midnipur, West Bengal, who presented to us in the IOPD with the chief complaint of diminution of vision in right eye for 20 days, which was insidious in onset, progressive, and associated with dull aching, piercing kind of sensational pain. It was also associated with diffuse headache, which was more at the temple area, dull aching, aggravating mildly on eye movement, relieving on medications, and not associated with any fever, vomiting, or aura. There's a history of minor head trauma 20 days back. According to the patient, she did not have red eye, any glare photophobia, flashes, floaters, desaturation of color, worsening of vision on increased physical activity. There was no other neurological symptoms also. And in the past history, she's not a known case of any chronic illness, no history of arthritis or neurological disorders, no history of medications used previously or ocular surgery. In the personal history, she has no history of any addictions and normal dietary habits, no family history, and she has not taken any treatment previously for her problems. On the general examination, she's conscious oriented with vitals stable and normal systemic examination and neurological examination. Coming to the ocular examination of the patient, her best corrected visual acuity in right eye is 660 with 6.6 in the left eye. Intraocular pressure on applanation tonometry is 19 in right eye and 14 in left eye. Color vision being normal, that is 25 by 25 charts on Ishihara chart both eye. Her extraocular muscle movements are full and free in both eye with mildly painful movement in the right eye. Facial symmetry and orbit with eyelid and conjunctiva normal in both eyes.
Her corneal size, shape, curvature, and transparency on slit lamp examination was normal in both eye. Sclera in the right eye had congestion just near the lateral canthus, which was confirmed as a scleral congestion on 10% phenylephrine test, and normal in the left eye. Her anterior chamber depth was normal with von Herrich's grade 4 in both eye with no cells and flare. Iris was normal with pupil normal size with sluggishly reacting in both eye. The lens was clear in both eye with no evidence of retrolentil cells and flare in both eye. Coming to the posterior segment examination for my patient, starting with the right eye, her disc was hyperemic with blurring of the margins in elevation, evidence of grade 3 disc edema. Her macular FR was dull with suspected SRF, and surrounding chorioretinal folds were present. Blood vessels were dilated and tortuous, especially around the disc. Peripheral retina had evidence of subretinal fluid, inferonasal to the disc with a smooth dome-shaped appearance suggestive of exudative RD, and superinasally also she had an ill-defined raised deep lesion with the retinal vessels running over it suggestive of choroidal mass. The left eye disc was normal size, shape, color, but mild nasal blurring of the margin was seen with normal cuppus to disc ratio and neuroretinal rim healthy. Foveal reflex was normal with blood vessels normal and peripheral retina was normal. I had the differential diagnosis of first being posterior scleritis, and point for its are the history of pain, aggravating myelin eye movement with history and with the examination finding of scleral congestion, disc edema and exudative RD also. Choroidal mass, the point supporting would be the suspected mass lesion and the exudative retinal detachment, and with the point against would be the pain and the age of the patient at which the metastasis won't present, and the bilaterality of it. The optic neuritis might also be a differential considering the history of pain and disc edema, but the comparatively good visual acuity, normal color vision, and the examination of scleral congestion and the absence of typical course would not suggest it. Then VKH could be a probable diagnosis with disc edema and exudative RD, but the extreme pain and no evidence of uveitis, like no cells in flare in AC and VC, would oppose it. So I would give a provisional diagnosis for the bilateral posterior scleritis for this case. Thank you.
Thank you. Are there any questions from the judges?
Yeah, it's regarding the investigation. The provisional diagnosis you gave is correct, and from your clinical diagnosis, you probably came to the diagnosis it is posterior scleritis. What other investigations should you do to confirm that it's a posterior scleritis?
Yes, sir. So, sir, posterior scleritis is a disease that we need to make a diagnosis for it, and definitely what is the cause for it for the further treatment also. So, to confirm the diagnosis, handy instrument that we can use in OPD basis would be a B scan that we can do and look for the T sign that is seen. So there will be a fluid in the subtenon space with the around the optic nerve head that we can see. So that would and with the thickening of the sclerochoroidal tissue around. So that would lead to or suggest will be suggestive of the posterior scleritis. And in my case, there was a subretinal fluid with exudative retinal detachment, which could be seen very well clinically, but OCT can be done to confirm it also, sir.
So what could be the cause in this case? Have you done any investigation to find out whether it is a immunological or infective etiology?
Yes, sir. So suspecting the autoimmune or the infective etiology, we have done a battery of tests. So her CBC with differential counts were normal, with ESR and CRP were raised, sir. And after that, the ANA and RA factor was negative. C-ANCA and P-ANCA were also negative for our case. We had also done a chest X-ray and Montague's test, which did not show us any significant finding for our case. And also the blood culture and VDRL was also done to rule out the infective causes in this case, sir.
How did you manage them?
Sir, for management of this case, because it's a posterior scleritis, a posterior cause, and definitely a severe one because presenting to us with disc edema and exudative retinal detachment. So we had started steroids, and we started with IV methylprednisolone, 600 milligram. It's a 14-year-old child. So we had given this pulse dose for 5 days. After that, we had put the child on 1 milligram per kg per day of on oral steroids, sir.
All right. Anybody? I don't know what is new in this, not my topic. So there's something to be asked on recent advances. Subudh sir, anything you would like to
Has
ask?
trauma has any relevance here? You said there is some
Sir,
trauma.
she gave a history. Yes, sir. So she gave a history of trauma, and when she presented to us, she was an untreated case, but definitely outside she was diagnosed as a traumatic retinal detachment. So that way, when the case came to us, and then we started investigating, and we found this exudative retinal detachment with a choroidal mass-like lesion, which might be a choroidal effusion after we made a diagnosis that we thought. So we started off from that, and for our case, as per the diagnosis and the way she responded to the treatment, so I don't think trauma had any relevance. It was a minor trauma.
Right.
So we are supposed to. No, we are supposed to give marks for 4 this thing, and the last point was on recent advances. I do not know any recent advances on this in the management, in the diagnosis, anything which is new. Bhumija, have you gone through the literature? Anything which is new about posterior scleritis?
So the immunomodulators that the increased use of immunomodulators that we've been using. So now, like the steroid sparing agents and people who are not responding to it. So mostly that methotrexate RA or GIA that is being used. But now increasing use of rituximab and tocilizumab that is coming up. So those are the recent advances, sir.
Yeah, okay. So I think methotrexate and mycophenolate and other things are being used now. Good. Okay. Thank you. Any other questions from any other judge? No. So we can go ahead to the next speaker.
Thank you, sir. Thank you.
Dr. Amit, start sharing your slides. Rita ma'am, did you want to ask something? You're not audible, ma'am. Dr. Amit, please share.
Yes, ma'am. I'm sorry for the delay. I'm just trying to do that, ma'am. Just a minute.
The next one in row can do, then you can follow.
Yes, ma'am. Okay, sorry for the delay, ma'am. Yes, please.
Dr. Ridhima, can you share?
Yes, ma'am. Yes, ma'am. I'm sharing my screen.
Okay.
Okay, is my screen visible, ma'am?
Yes, it's clear.
Just a second. Okay, just okay. So good afternoon, everyone. Today I'm presenting a case of a 65-year-old male resident of Kendrapara and carpenter by profession who presented to us with complaints of diminution of vision in left eye since 2 months. Patient was apparently asymptomatic 2 months back when the patient complained of decreased vision in left eye 2 months back following injury to the left eye by a wooden stick while he was hammering it. The diminution of vision was sudden in onset, gradually progressive, constant, non-fluctuating, both for distance and near, and impaired his ability to perform his daily work. It was associated with pain, which was sudden in onset, severe in intensity, non-radiating, and present constantly throughout the day. It was also associated with redness, which was sudden in onset following trauma. It was not associated with watering, photophobia, or glare. It was not associated with diplopia, floaters, or flashes. Patient took treatment at a local hospital 2 months back following trauma, where he was given treatment with topical and systemic medications, and he gave history of instilling topical eye drops around 8 to 10 times a day. And following that treatment, his symptoms of pain and redness reduced, but the problem of diminution of vision persisted and progressed. Past personal and family history were all non-significant. General examination, patient was conscious, well-oriented to time-pacing person. Rest, systemic and general examination were normal. The ocular examination, uncorrected visual acuity in right eye was 636 with no improvement on subjective refraction or pinhole. In left eye, visual acuity was uncorrected visual acuity was 6 counting finger 1 meter with no improvement on subjective refraction. Near vision in right eye was N18 and in left eye could not be recorded. Color vision in right eye was normal and left eye could not be recorded due to the decreased vision. Extraocular movements were full free and painless in both the eyes, and intraocular pressure as measured by Goldman's applanation tonometry was 18 millimeters of mercury in right eye and 20 millimeters mercury in the left eye. Ocular. Then coming to the local examination, I'll be describing the examination of the left eye first. So the orbital margins were intact. There was no tenderness or crepitus felt. Eyelids were normal in position. No ecchymosis, edema, laceration could be seen. Eyebrows and lashes were normal. Lacrimal sac and gland area was normal. In conjunctiva, there was no congestion, subconjunctival hemorrhage or chemosis. Cornea was normal in size and shape. Surface was regular, transparent, smooth. Sensations were intact. No vascularization was seen. No epithelial defect was seen. Fluorescent test was negative. In stroma, there was no edema or opacity. Endothelium was normal. No pigments or KPs were seen. Sclera was normal. Anterior chamber, so the peripheral anterior chamber depth was variable. From 9 to 1 clock hours, it was Van Herrick's grade 3. And from 2 to 8 clock hours, it was Van Herrick's grade 1. Central depth was normal. Anterior chamber was quiet. There were no cells, flare, hypopyon, or hyphema seen. In iris, iridodonesis was present. Sphincter tear was noted from 2 to 4 clock hours and 5 to 7 clock hours. No atrophic patches were seen and no PXF deposits were seen. Pupil was mid-dilated around 6 to 7 millimeters and it was single central round and very sluggishly reactive to direct and consensual light reflex. The lens was subluxated inferiorly and displaced anteriorly. Phacodonesis was present. No zonules were seen in the area of subluxation. And on the anterior lens capsule, no pigments were seen, no pseudoexfoliation material was seen. Anterior capsule was intact and nucleus sclerosis grade 3 along with cortical cataract was present. Anterior vitreous face was normal with no pigments or cells could be seen. In the right eye, all the examination of the anterior segment was normal. Only in the lens, immature cataract of the nucleus sclerosis grade 2 with posterior subcapsular cataract was present. Then fundus examination, in both the eyes, the media was hazy. And apart from that, the fundus examination was normal in both the eyes. No holes, breaks, or tears or detachments were seen in the left eye. On performing gonioscopy with Goldman's 2-mirror lens, we could see that in the left eye, the inferior angle was Schafer's grade 0 to 1. Nasal and temporal angles were Schafer's grade 1 to 2, and the superior angle was 2 to 3. In the right eye, all the angles were open. So to summarize, this is a case of a 65-year-old man who presented with complaints of decreased vision in left eye since 2 months following blunt trauma. Best corrected visual acuity was 636 OD and counting finger 1 meter OS. And on examination, variable of the left eye, variable peripheral anterior chamber depth with sphincter tear, anterior displacement, and inferior subluxation of the lens was noted. So the provisional diagnosis in my case is in the left eye, there is inferior subluxation with anterior displacement of lens with senile cataract with secondary angle closure, status post blunt trauma, and in the right eye, senile cataract. Thank you.
Thank you, Dr. Ridhima. Any questions from the judges?
This is who? Ridhima? Huh?
Yes, sir.
Ridhima.
All right.
What is the size of the foreign body?
There was no foreign body, sir.
No, that wooden stick you said, what the size of the wooden stick and what the direction of the wooden stick?
So when he was working, because he's a carpenter, when he was hammering that stick, it was around like 1 feet long stick, which it just bounced in the opposite direction and it hit his left eye.
Was it sharp one, or it's a blunt one?
No, it was a relatively blunt stick, sir. It just went and hit him head on, like on his eye.
Okay. Right. So Ridhima, you presented well, but
Yes.
The diagnosis obviously is straightforward. There is a traumatic subluxation of the lens anteriorly.
Yes,
so
sir.
what do you anticipate? What complications would you anticipate in managing this? How did you manage? And what complications do you anticipate in management of this patient?
Yes, sir. So on our examination and given the patient, his main complaint was diminution of vision. And because rest of the anterior segment examination was all normal, sir, so we proceeded to perform cataract surgery for this patient. While performing cataract surgery, because the lens was subluxated inferiorly and displaced anteriorly, we had to do the cataract surgery in accordance with that. So it was So we had to use capsular tension rings while doing the cataract surgery, and so we.
Okay. So, no, have you seen the surgery or just telling it from the books?
No, sir, I saw the surgery. It was done.
Ideally, how many days you should wait to do a surgery in a traumatic subluxation lens, and planning a surgery with just capsular tension, capsular supporting hooks, would that suffice? When you say
Sir,
that subluxation is much more than 12 clock hours, more than 6 clock hours, in that case, would it suffice? And what lens was used?
Yes, sir. So, as far as the timing of the surgery, sir, if there are no signs of active inflammation, because there was no cells flare and no active signs of inflammation, we could have proceeded with the surgery right away. And for the surgery, because the dislocation was quite large, so we thought of proceeding with the tension ring, but because the lens was severely subluxated, we actually just did lensectomy, like we just removed the entire lens mass as such. Without,
you said you used capsular tension ring and iris hooks.
So that we can we can plan for that in case in other case, but in this case, because there were no zonules in the area of subluxation, we planned to do that with the tension rings, but on table we didn't feel that it was appropriate, so we went ahead and removed.
Usually, if you have a 6 clock hours subluxation, ideally, if it is possible to salvage the capsule, then you should use a segmental ring along with CTR. So the cataract is very hard. Obviously, that is difficult. But otherwise, up to 6 clock hours, I think you can still manage to do a phaco supporting the superior. The subluxation was inferiorly, so naturally you need to support the superior fornix.
Yes, sir,
superior equator of the capsule, and of course do a segmental fixation of the bag. But if the surgeon feels no, it is too much, because these traumatic cataracts or traumatic subluxations are usually stable. Okay.
Yes,
so you do not need to really remove the lens if it is possible to retain the capsule. The other 6 clock hours will remain stable.
Yes, sir.
Okay. So, what lens did you put? How old is the patient?
Patient is a 65 year old.
So what lens did you put?
So we put a posterior iris flow lens.
Okay, so iris fixation lens you put.
Yes, sir.
Okay. In recent advances in the management of subluxated cataract, what options do you have?
So with regard to the kind of lens that we implant, sir?
Yeah, it's okay. The procedure, the kind of lenses that you use, techniques of implantation.
Okay. So, sir, when we are managing for this case, I'll be talking with respect to this case while we are planning for cataract surgery, because the anterior chamber was also shallow. So we need to make sure that the AC depth is maintained.
So I'm asking in the recent. I'm asking about a subluxated cataract. Okay, and you are planning to give a IOL in that. What recent advances in the techniques or types of lenses that you know of, which you can say for a subluxated cataract? Basically, you are going to fix a lens. Okay, so what are the types of lenses? What are the techniques? What are the techniques you know of?
So we can place a scleral fixated IOL in case where in the back placement fails, and if it's not stable, so we can use a scleral fixated lens, or we can give a iris flow lens, or we can use a 3-piece lens for better stability. And at the same time we have to perform vitrectomy, anterior vitrectomy, to make sure there is no.
Thank you, Vidima. I think you are not getting my point. It's okay. Thank you. Any other judges, sir?
What is the status of macula?
The macula was normal, sir. It appeared normal.
Did you do assess pre-operatively or post-operatively?
Sorry, sir.
Did you assess the macula preoperatively or postoperatively?
Both, sir. Even both preoperatively and postoperatively, the macula appeared normal, sir.
Okay, carry on. Okay, thank you.
Next, let's go to next.
Dr. Amit, please start sharing
Yes,
your slide.
Yes, ma'am. Yes, ma'am. Am I audible and is my presentation visible, ma'am?
Yeah, both.
Yes.
Okay, thank you. Good afternoon, everybody. I am Dr. Amit Panda from KPM Rotary, and my mentor is Dr. Aparna Dwivedi. And the case I am going to present today is of a 64-year-old male patient from Jajpur, a farmer by occupation who came with chief complaints of swelling and redness and puffiness of the left eyeball for the past 8 months. The swelling was insidious in onset, gradually progressive, more in the morning, and which increased on bending forwards, and it was painless in nature. It was also associated gradually progressive, painless decrease in vision and double vision since the past 1 month. And there was also associated redness in the left eye, and it was not associated with any similar complaints in the right eye. There is no history of ocular trauma or head injury, headache, thyroid disorder, fever, chronic cough, any recent COVID infection, or weight loss, loss of appetite, or smoking. The patient is not a known case of diabetes or hypertension, and there is no history of any previous ocular treatment. Personal history and family history are not significant. General examination was within normal limits with no signs of lymphadenopathy and no clinically visible neck swelling. Vitals were stable. Systemic examination was also within normal limits. Coming to ocular examination, head posture was erect, face was bilaterally symmetrical, and both eyes are orthophoric in primary gaze. Right eye examination was essentially within normal limits with best collected visual acuity of 6.6 partial with plus 1.75 SEER. Left eye visual acuity was 612 with no acceptance. Color vision was normal, and intraocular pressure measured by applanation tonometry was 16 millimeters of mercury in the left eye. Coming to the proptosis evaluation, the first figure here shows the worm's eye view from below, and the second figure shows the Navziger's view from above, showing left eye proptosis, and the third figure shows the measurement of proptosis with Hertel's exophthalmometer, which revealed an axial proptosis of 23 millimeters with a base of 107. And there was fullness was present on inspection with an insinuation was possible on palpation. There was no resistance to retropulsion, but Valsalva was positive, which led to an increase in the chemosis and congestion of the left eye proptosis, and no audible bruit was heard on auscultation. And ocular movements were restricted in the left eye. There was restriction of abduction in the left eye with levo elevation, levo depression, and dextro elevation. Then the eyelid examination, there was periorbital edema of both the upper and lower eyelids with conjunctival chemosis and congestion, along with dilated tortuous episcleral vessels, as seen in the second figure. Cornea examination was cornea was clear, along with sensations were intact. Then anterior chamber was shallow, and pupil showed RAPD of grade 2. Then retina of the left eye showed hyperemic disc with presence of disc edema and dilated tortuous vessels. So my provisional diagnosis for this case is unilateral axial proptosis of the left eye due to arteriovenous fistula.
शुभ सर आपण पचारंतु मते
Yeah.
शर्मिष्ठा को जे बहुत अधिक पचारछुती लंबा हे होछि
Sorry. The limit is 4 minutes only. You can ask within 4 minutes. Okay. So you said there is a arteriovenous fistula. Did you hear the bruit about the?
No, sir. Bruit was not heard, sir.
It is not heard.
No,
and
sir,
is
not
it swelling is a pulsatile?
Sir, not pulsatile. Sir, no.
Yes.
Yes, sir. So not all cases of fistulas, arteriovenous fistulas are pulsatile, sir, and mainly sir direct fistulas which are have due to direct connection between the carotid artery, internal carotid, and cavernous, they generally present with pulsatile proptosis and also bruit.
Is it unilateral or bilateral?
Sir, this was unilateral, sir.
This is. Do you get normally unilateral or bilateral?
Sir, more commonly is unilateral, but even sometimes bilateral can be seen, sir. Bilateral causes can also be seen, sir. Cases.
Any other systemic anomaly associated with that?
Sir, systemic anomalies, sir, sir, aneurysms can be there, sir. Cranial aneurysms can be there. Then, apart from that, sir, any AV malformations can be present, sir. Congenital AV malformations can also present as such.
What investigations suggest?
Sir, investigations, sir, blood parameters were done, sir. CBC complete blood count, ESR were normal in limit.
Why is that necessary? Why? I don't think there is a need to do.
Sir, to rule out if because of the most common differential for this case can be thyroid or vitropathy. So to look for inflammatory causes or any other infectious causes which may be present, sir, like tuberculosis also. So thyroid profile also has to be done. Then after this neuroimaging.
If you are saying on Valsalva it is increasing, there is obviously it is a carotid fistula or a malformation. Okay, so the imaging is the best way to know. What is the class?
Yes, sir.
Tell me the classification.
Sir, classification of
carotid cavernous fistula.
Sir, it is 4 types. Type A is a direct fistula between the internal carotid and the cavernous sinus. Type B is the type B, C, D all are indirect fistulas. Type B is a meningeal branch of the ICA with the cavernous sinus. Type C is the meningeal branches of the external carotid with the cavernous sinus, and type D is both type B and plus type C.
All right. And one more thing.
Yes,
what is the most common sequelae of a carotid cavernous fistula?
Sir, it can lead to complications. So it can lead to SDH or intracranial hemorrhage, sir. It can lead to that mainly, sir.
Ocular?
Ocular, it can lead to optic nerve compression also. Sir, optic nerve compression, then gradually.
More than 60% of these patients develop glaucoma. Okay, that's the first.
Yes, sir, glaucoma also. Yes, sir. Sorry, I forgot. Sir.
Yeah. All right, sir.
How to manage the case?
Sir, management, sir, we have to do neuroimaging studies, as sir already told, sir, CT scan, MRI, mainly, sir, most importantly is with contrast, and which can show us in swelling or increase in the thickness of the superior ophthalmic vein and exocular muscle enlargement. But sir, the diagnostic test will be a digital subtraction angiography to look for the particular site in either the ICA or internal carotid or the external carotid, and the fistula site can be diagnosed with DSA. Then so treatment can comprises of so basically mainly it is done with presence of, if it is a direct fistula, and then more intra-arterial route is followed, and embolization, so coil, either with coil embolization or it can be done with glues such as butyl acrylates or acrylate glue can be used. But if it is an indirect fistula, we can use more commonly transvenous, intravenous route is more preferred, and coil embolization is done, sir.
Okay.
So ophthalmologist has nothing to do. All by the neurosurgeon?
Sir, mainly, it is a neuro interventional radiologists and neurologists are more required, sir.
Right. Thank you.
Thank you so much. Thank you.
Over to the next speaker, Dr. Asmita. Please share your slides.
Yes.
While Dr. Asmita is sharing, the next two speakers can get ready with theirs. Dr. Satyabrata and Dr. Gayatri.
Ma'am, I cannot share my screen already.
Please unshare. Please unshare. Dr. Amit.
Amit, stop sharing. Amit, do you listen us? He is not able to hear, I believe.
Dr. Amit?
No, he's gone, I think.
He has gone to drink. He has gone to drink, sip a cup of water.
Still is there.
I think who
No,
is our...
You can't. Nobody can do that unless he's answer it.
No, I think one of our admins can probably do that.
I think. Yes, now it's good. Okay. Asmita, start.
Ma'am, is my screen visible?
No, yes, now it's visible.
Good afternoon. My case presentation is about a patient who is a 70-year-old male resident of Dhama, Sambalpur. He presented to our OPD with complaints of pain, redness, severe diminution of vision, right eye more than left eye, since 3 months. The patient had attended multiple local hospitals at recurrent intervals for similar complaints in the past, for which he had received various systemic antibiotics and topical antibiotics, as well as topical steroids and mediatics. He was also having a history of treatment for dysuria. There was no past history of any prolonged illness like diabetes or hypertension or tuberculosis, though he had a history of treatment for urinary tract infection in the past. The patient was a non-smoker, non-alcoholic, and belonged to a lower socioeconomic status. There was no significant family history related here. The patient did not have any associated complaints of arthralgia, hair loss, chronic cough, weight loss, fever, oral ulcers, genital ulcers, rashes, or any abnormal bowel habit. On examination, the patient was conscious, oriented to time, place, person, was of moderate build, well nourished. On his systemic examination of CNS, CVS, GIT, and respiratory system, all were within normal limits. His head was erect, there was no facial asymmetry present, and both eyes were orthophoric. On ocular examination of the patient had a narrow interpalpebral fissure. There was conjunctival congestion as well as circumcorneal congestion in both eyes along with nasal pterygium. The patient on corneal evaluation showed epithelar as well as stromal edema of the cornea. Anterior chamber was irregular, it was shallow. There were pigmented keratic precipitates seen on the endothelial surface, and the contents were unclear because of the irregularity. There was a fibrinous membrane present occluding the pupil, thus both the eyes' lens could not be assessed. On presentation, the patient presented to us with a right eye PL positive and PR inaccurate, and left eye hand movement positive. Presenting intraocular pressure of the patient was right eye 47 millimeters of mercury and left eye 26 millimeters of mercury. These are the slit lamp pictures of the patient on evaluation, in which we can already see the presence of pigmented keratic precipitates on the endothelium, presence of occlusio pupillae fibrinous membrane over the pupil, irregular anterior chamber. These are further pictures, pictures regarding the patient. Thus, my provisional diagnosis and evaluation would be that the patient is a case of chronic anterior non-granulomatous uveitis with occlusio pupillae with iris bombae, secondary glaucoma in both eyes with the possibility of associated urethritis from his past history. Thank you.
Thank you, Dr. Asmita.
Yes, ma'am.
Over to the judges for the questions.
So 70-year-old man with having a bilateral uveitis, you mean to say?
Yes, sir.
Okay. Does he give any history in the past?
Yes, sir. There was frequent history of similar such complaints for which he had received treatment elsewhere also.
But within 3 months or before 3 months also?
So that was more than 3 months.
More than 3 months. How many? Yeah, Ashok. Yeah.
So my question is, if there was signs of urinary tract infection, do you think it is a case of Reuters?
So yes, it could have been, but we did not evaluate other associated features like presence of genital ulcers And on examination, there were no similar pustular or any keratic eruptions over palms or soles. So it cannot be confirmed, as well as there was no HLA 27 evaluation because the patient cannot afford it. So, but it could have been in the spectrum of Whitaker's disease.
Okay, the most important is the age, age, usually it is younger age group, no? This is not.
Yes.
So what possible diagnosis would you give? What is the possible bilateral uveitis, such a severe amount of uveitis with secondary glaucoma? What could be the possible cause?
Sir, for his age group and socioeconomic status, it could be tuberculosis, sarcoidosis, but absence of any granulomatous changes rule out those conditions. It can be viral keratouveitis as well, but there was no history of eruptions either on the face or no history of eruptions in genital area. So that can also be ruled out.
So this is most likely a non-infectious cause of uveitis, most likely psoriatic or a IBD or those type of things, autoimmune induced, HLA-B27. Okay. What is the course of management? How do you manage this case?
Sir, the first line of management should have been control of inflammation, but due to chronicity, for us, the first line of management was control of intraocular pressure, and we started the patient with oral tablet acetazolamide to set for 3 days. Following this, there was a diminution of congestion, and it was followed by a laser peripheral iridectomy to relieve the increased intraocular pressure, and it was followed up with topical anti-glaucoma medication.
And
So also steroid should be prescribed topical for the chronic uveitis condition.
And no.
Sorry, we have to also prescribe mediatics and cyclotherapies.
Yeah.
Relieve the
Right. So
side
systemic immunosuppressions along with topical, along with mediatics and glaucoma management.
Yes.
Okay, I think we are exceeding time. Let's go to the next.
Yes.
Next speaker, Dr. Satyabrata.
Yes, ma'am.
Please share your slides.
Yes. Ma'am, is it visible, my slides?
Yes.
Okay, thank you, ma'am.
Your slides are not done. Now it's visible.
Yes. Ma'am, can I start?
Yes. Please start.
Good afternoon to all the members present in this webinar, respected judges and all the panelists. I am Dr. Satyabrata Jana, going to present a case of cataract masquerade. 45-year-old male came to us 6 months back with complaints of gradual painless diminution of vision in both the eyes since last 1 year. In history of present illness, the patient
Satyabrata, change your slides. Satyabrata, change your slides.
Okay.
Full screen.
Go to full screen and change your slides.
Okay, sir. Sir, is it visible now?
Now you make it a full screen also. Full screen.
Make it full screen.
Sir. Sir, actually I'm doing, but it is not showing in the app, sir. Zoom. So.
In the right side, you will have right side. If you go to the right side, there is a sign.
Go with the cursor to the bottom down where it is written 70%. Go down.
Yes, sir. Yes, sir.
Yes, near the 70%, there is a full screen. Your cursor is not visible there. It should be.
No, not like
90. It is good. See, you are pressing on the plus side. I am talking about 80.
No,
where
sir,
it is
no,
written
sir.
80 on the left side of that.
Okay, carry on now. Otherwise, carry
Sir,
on.
actually, I'm doing the slides, sir, but sir, it is not showing in the Zoom.
The slideshow is there, but if you cannot do it, leave it. Continue then.
Sir,
Okay.
can I stop and start again? It will be visible.
It's okay.
No, now carry on.
Okay.
Continue.
We can see.
Patient, okay, sir. Patient was apparently all right 1 year ago to start with the developed diminution of vision in both the eyes for distant and near. It was insidious in onset, which is gradually progressive in nature. The patient had difficult to drive. There was diminution of vision more in day than night. There was no history of pain, watering, redness, colored halos, and there was no history of any trauma to the eye. In the past history, there was no such similar complaints in the past, and he had history of type 2 diabetes mellitus since 3 years and was on oral hypoglycemic agents. There was no history of use of any other systemic medications. And there was no any relevant family history, or the personal history was well, and he had no history of any smoking and alcohol intake. In general physical examination, he was well built, and all the vitals were stable.
Change your screen.
Sir, I am starting it again, sir. Actually, sir.
Go to the next slide.
Okay, ma'am. It will be visible now. Ma'am, sir, is it visible, sir?
Yeah. Okay.
Yes.
Now it is full screen.
Yes, sir. In the personal history, he had no such relevant personal history, and he had no history of any smoking and alcohol intake. In general physical examination, the patient had well built, and all vitals were stable. In the ocular examination, the uncorrected visual acuity of the right eye was 6/18. With pinhole, it was becoming 6/9. In the left eye, it was 6/12. With pinhole, it was 6/9. Near vision was N8 in both the eyes, and color vision was normal. The patient had normal head posture with the maintained facial symmetry. Patient was orthophoric with aligned visual axis. On slit lamp examination of the anterior segment in both the eyes, right and left, eyelid, eyelashes, palpebral aperture, lacrimal apparatus, conjunctiva, sclera, cornea, all were within normal limit. And anterior chamber, it was normal in depth, both central and peripherally. The Van Herrick's grade was 3, and it was optically clear in both the eyes. In the right eye, iris was also normal. Pupil was also 3 mm, single and normally reactive to light in both the eyes. In lens, in the right eye, there was posterior subcapsular cataract with grade 2, that is P2. And in the left eye, it was posterior subcapsular cataract grade 1, P1. And the IOP measured using Goldman applanation tonometry. In the right eye, it was 18, and in the left eye, it was 17 mm HE. On gonioscopy using 3 mirror Goldman, it was grade 3 according to the Safford's grading system in both the eyes. On fundoscopy, the media was clear in both the eyes. In the right eye, the optic disc was normal in color, shape, size, color, well-defined margin. Curve disc ratio was 0.8:1. There was thinning of neuroretinal rim at superior and inferior margin. In the left eye, there was cupping 0.7:1. There was thinning of neuroretinal rim at superior and inferior margin. And in the right eye, there was bionetting sign at the superior and inferior pole. Laminar dots and present in both the eyes, both the disc, and there was peripapillary atrophy present. But in the right eye, there were small flame-shaped hemorrhages at the superior temporal aspect of the disc margin. The AV ratio 2:3 foveal reflex was present, and rest peripheral fundus were within normal limit. With a complaint, my provisional diagnosis is with a complaint of progressive diminution of vision and a finding of PSC. And finding a PSC in both the eyes, and 0.8:1 and 0.7:1 cupping in the right and left disc, and a superficial flame-shaped hemorrhage at the disc margin. A provisional diagnosis of posterior subcapsular cataract with normotensive glaucoma was made. He was advised for hospitalization for further evaluation, to which he refused. He was put on a prostaglandin analog. He was lost to follow-up and again showed up on 17th of May, and his visual acuity was stable. IOP was 13 and 14 mm.
Okay, you have to stop at provisional diagnosis, Satyavata. Okay.
Okay, ma'am.
Can we go for the discussion, sir, judges?
Okay,
Picture
what?
showed what it is a fundus picture. Last
Show the
sentence.
Yes,
Yeah.
sir. Sir, this is the fundus picture, sir.
Okay.
Sir, this is of the right eye, this is of the left eye, sir.
Okay, then stop sharing now.
Yes.
Suppose the patient, you wanted to hospital the patient.
Yes,
What
sir.
investigation you would have done in this patient?
Sir, in this patient, sir, first we have to check for the any systemic causes, sir, and then we'll test for the diurnal variation test. Sir, a diurnal variation test we have to do. So then we'll do the perimetry, and sir, if possible, sir, to detect the pre-perimetric glaucoma, we'll do the OCT, sir. That is a nerve fiber layer analysis. Sir, this test, sir, I want to do, sir.
Okay, so you say it is a normal tensum glaucoma.
Yes, sir.
Right?
Yes, sir.
Is intraocular pressure absolute or relative? I mean, intraocular pressure is an absolute figure or it's a relative figure? Is it related to corneal thickness or not?
Yes, sir. Sir, intraocular pressure is related to the central corneal thickness, sir. Sir, in case of if the central corneal thickness is thin, the intraocular pressure will be underestimated, and if
Satyabrata, suppose I say this patient has a central corneal thickness of 420, and I am presenting IOP was 18 and 19. So would you still say it is a normal tensum glaucoma?
Yeah.
Sir, we'll go for the corrected IOP calculation, sir. I forgot the formula, sir, which is related to the thickness.
Okay.
Yes, sir.
Okay.
The corrected IOP calculation, sir.
So you should contradict me. No, sir, I should still say, because in normal, what is the typical characteristic of normal tensum glaucoma that you find in this?
Sir, there is cupping, sir. Cupping, sir, and
Cupping
thinning
is
of
there in all glaucoma.
Not cupping.
Cupping is there in all glaucoma. What type of cupping? What is the typical characteristic of the cupping, and what is the typical finding?
Sir, sir, that is the inferior rim, sir. Sir, the ISNT rule is means.
No. That is for all glaucoma, Baba.
Yes, sir.
You have to focus on a flame-shaped hemorrhage of the disc margin,
yes,
which
sir.
is common. It is common in normal tensum glaucoma, and the cupping has a slopy roof, slopy margin. Okay, it's a gentle slope. You don't get a deep cup. It's a shallow cup. Usually, it's slopy margin. Okay, so these two findings are there. So you suggest that it is probably an NDG. Okay, not other points. All other points which you said are for any open angle glaucoma.
Yes, sir.
Rita madam is not there.
Rita,
Yes, Rita ma'am is there.
Rita, your patient.
Rita madam, we can't hear you, ma'am.
Rita is, I think, audio problem is there. She's not able to hear us. As you are not audible also.
I tried calling to her, but she's logged in.
She has some problem. I think how to manage this case, Satyabhat?
Sir, in this case, sir, actually, sir, the patient was from the periphery, so that, sir, actually, we should give beta blocker along with a prostaglandin analog. But sir, we gave only prostaglandin analog.
But you have given prostaglandin, the pressure has come down to 12-13. You don't want to go below that. So, but his concern is different. Why he has come to you?
Yes.
Why he has come to you? He came to you for the dimness vision. What do you do for the dimness vision?
Yes, sir, we given sir glasses, sir, prescribed glasses.
Do you think that he will improve with glasses? Because post-subcapsular cataract.
Sir, actually, sir, in the pinhole, sir, it became 6/9, sir. But sir, the vision was completely, sir, blood, sir. But in the pinhole, it was improving. So that sir, we give PG analog, sir, along with the glasses, sir, for the patient satisfaction.
Okay, thank you. We'll go for the next case. We'll go for the next person. Okay, thank you.
Thank you, sir.
Next, Dr. Gayatri, share your slides.
Yes, ma'am. Yes, ma'am.
I think there is echo. She has a second device on.
Who?
Gayatri.
Acha. Okay, Gayatri, then Jyoti, where is Jyoti? You can share also, Jyoti. Gayatri said, yeah, carry on. Yes, he has some issues, I believe.
And Dr. Jyoti can share.
Jyoti can do.
Dr. Jyoti, are you ready?
Yeah, I think Jyoti is sharing it.
Yes, ma'am. Good afternoon. I'm trying to share my screen. Just give me a few minutes. Hello.
Yeah, we can see your screen.
Yes. Can you see my screen?
Yes.
Am I audible?
Yes.
Yeah, go ahead.
Yes.
Go ahead.
Okay.
Go ahead.
Good afternoon, everyone. I'm Jyoti Goyal, and I'll be presenting a curious case of anterior chamber fibrin, which I have prepared under the guidance of my mentor, Dr. Anita. So in our OPD, a 39-year-old patient came who was manual labor by occupation, hailing from Cuttack, Odisha, with the chief complaint of redness in the left eye since last 10 days, which was associated with watering, pain, and blurring and gradual diminution of vision since last 10 days. So redness in the left eye, it was sudden in onset, it was progressive in nature, and it was associated with watering. There was mild to moderate dull kind of pain, which he said it increased while he went to sunlight and while he sees some bright light. And the blurring of vision was there, which was gradually increasing. There was history of recent ophthalmic consultation at a local eye hospital where he said they diagnosed it as conjunctivitis and prescribed some medication, details of which were not known. So he has similar episodes of redness in the other eye 1 year back with similar complaints of watering, pain, and which he said it resolved after taking some treatment, which he's not aware of. He said there is no history of wearing any glasses. There is no history of any recent or previous ocular or head injury. He is not a known case of diabetes, hypertension, asthma, or any systemic disorder. His family history is non-contributory. 1 second. He did not undergo any lasers and he has no allergies. Currently, he is putting prednisolone acetate eye drops and chloramphenicol eye ointment and CMC eye drops. On general examination and systemic examination, they were unremarkable. On visual acuity testing left eye, his vision was decreased to 20/40 for both near and near was also decreased to 6/18, but right eye vision was normal. On slit length examination, right eye findings were within normal limits. Left eye findings, I would like to demonstrate in the next slide with the help of slit lamp images. So there was mild lid edema, and there was diffuse conjunctival congestion. There was episcleral congestion and conjunctival congestion both, as we can see in this conjunctival vessels which are bright red in color and episcleral vessels which are deep red in color. There was circumciliary congestion as well. In this picture, I would like to demonstrate the presence of fibrin, which looks like a cobweb-like structure, which is attached from behind the surface of cornea and till the pupillary margin. We can see fresh, fine to medium-sized, diffuse, non-pigmented, non-granulomatous KPs also. We can see in this picture from 4 o'clock to 11 o'clock, there are posterior synechiae, and there's AC reaction as well. And pupil was irregular and sluggishly reacting to the light. On IOP measurement with the Goldman applanation tonometry, both side IOP was within normal limits. Fundus examination, right eye was within normal limit. Left eye disc was very hazily seen, and first order vessels could be seen, but details we could not comment. So I would like to reach a differential diagnosis of seronegative spondyloarthropathy associated or HLA-B27 associated non-granulomatous anterior uveitis or endogenous endophthalmitis. So to reach to a provisional diagnosis, we went back and took some specific history of recent fever or infection, any history of hospital admission or vaccination, any history of drug abuse, any recent history of urinary tract infection or respiratory infection or GI, any history of associated allergies, rashes or skin ulceration, or any history of any significant weight loss. But and we came across that he had a history of lower back pain since last 2 years, which is more in the morning hours, and get relieved on doing some activity and stretches that is suggestive of inflammatory kind of joint pain. So summarizing my case, young male, recurrent redness in both the eyes, that is ping pong pattern, and inflammatory joint pain, iridocyclitis kind of picture, unique characteristic feature of fibrin in the anterior chamber. So I would like to give a provisional diagnosis of seronegative spondyloarthropathy or HLA-B27 associated non-granulomatous anterior uveitis. Thank you.
Did you do the HLA testing?
Yes, sir. Like right now, after for the management of this case, I would like to do few tests to confirm my diagnosis. I would like to do blood examination of CBC, ESR, CRP, inflammatory markers, and I would like to do HLA-B27 testing as well. And I would refer my patient to a rheumatologist if my HLA-B27 tests come out to be positive.
What is the role of ANCA?
ANCA, sir, in my case, we would like ANCA is mainly positive in SLE kind of pictures or granulomatous polyangiitis pictures, vasculitis picture. ANCA is positive, but I am not suspecting that in my case, sir.
How do you treat this patient?
Sir, from ophthalmic point of view, I would like to start on aggressive steroid therapy. Like I would like to start my patient on prednisolone acetate eye drops 1 hourly for 3 days, then 2 hourly for next 3 days, and I would like to follow up my patient for 1 week. After 1 week, I would like to call my patient and review my patient, and I would like to start him on atropine as well 3 times a day. And I would refer him to rheumatologist if my HLA-B27 comes out to be positive.
Suppose it is negative.
Yes.
Okay, if HLA-B27 is negative, so the other history, the other diagnosis that I could think of was endophthalmitis because of the presence of fibrin. So history-wise, he does not give any relevant history of trauma or any vaccination or any infection that is suggestive of.
Since you gave that as a provisional diagnosis, as a differential diagnosis, then in the management, you should have told about a B scan. No?
Yes.
Yes,
Which
yes,
you did not
yes.
say.
For posterior segment evaluation, I would like to do a B scan as well.
Yeah. So in the management, you should have told that. I
Yes,
did not
yes,
say.
yes.
You only
Yes.
focused on your primary differential diagnosis, not the secondary one. Right?
Yes, yes, yes.
Right. So suppose it is a juvenile arthritis, okay, and it is still HLA-B27 negative. Would you like to still send the patient to your immunologist for medications, or would you like to start the patient on immunosuppressants with you? And if you are starting with you, what investigations or what monitoring of the systemic monitoring would you be doing on immunosuppression? Let's say you are putting the patient on methotrexate or azathioprine. So what?
Sir, I would. Sir, JIA has no redness, and I would like to. If I would like to start the treatment, then I would like to have a baseline investigation, blood investigation before starting the treatment of methotrexate, or like I would like to do LFT, KFT, CBC, and if or better would be if I refer my patient to some immunologist or rheumatologist, and I would like to do RA factor, HLA-B27. So all this panel I would like to do to confirm my diagnosis of JIA.
These are the common cases we come across in our day-to-day practice. Every time we do not send the patients to the immunologist because the immunologist may not be available everywhere. So how
True,
we
sir.
can manage? Yeah, we have to manage ourselves first. So how long you will give the steroids and you will see the response, then you think about the immunological agents, you know. So,
So you
how
need
long
to
you
start
continue
the patient on steroids. Definitely you have to start the patient on oral systemic steroid. See the response, see whether the patient is steroid responder or not. Then think of going on to a other autoimmune immunosuppressant drug.
Yeah, right.
Right.
Yes, sir.
Okay.
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 Anything? Any recent advanced aspect of this particular case? Would you like to highlight on anything on recent advance?
Recent advances. Sir, one antibody adalimumab is their drug, which is monoclonal antibody, which has been used for the treatment, and tocilizumab. All these are the recent
Any
advancement that
intravitreal? Jyoti, any intravitreal?
Intravitreal. Um,
Yes. What
Sir,
intravitreal implants?
implants. And or Ozuridex, I think. I'm not sure. Ozuridex
Azudex, you
implant.
mean? Azudex?
Yes, intravitreal implant. Or I read about it, but I can't remember the name.
Okay.
Ozuridex, I think.
Sir, can we go to the last speaker, sir?
Yes. Yes, please go to the next speaker. Okay, thank you, Jyoti.
Thank you, sir.
Yes,
Thank you.
Yes, ma'am.
Over to the
Ma'am, I'm audible?
Yes, you're audible.
Ma'am, my slide is visible now?
Yes. Yes, carry on.
Yes, it's visible.
Make it full screen. Full screen.
Yes, sir. Yes, sir. Yes, sir. A very good afternoon to one and all. Myself, Dr. Gayatri Devi Palo, want to present a case of shrinking eye. 20-year-old male presented to us with a chief complaint of right eye becoming small.
Gayatri again. Sorry, Gayatri again. You have same problem. Make it full screen and change the slides. Slide is not changing.
Sir, yes, sir.
Okay.
It changed, I think.
Yes, sir. Yes, sir. I'm doing so. Sir, is it full screen now, sir?
No.
Sir, here it is showing full screen, sir.
Let it be.
Yes.
Yes, sir. 20-year-old male complained to us with a chief complaint of right eye becoming small since last 1 month, and weight loss since last 1 year, and intolerance to heat and excessive sweating and fine tremor. Patient was apparently all right 1 year back. To start with, he developed loss of weight, which is associated with excessive sweating and heat tolerance, fine tremor of hands, for which he consulted general physician and was detected with hyperthyroidism and was advised medication. After 4 months, he discontinued the advised medication. Now, since last 1 month, he noticed that his right eye was shrinking and appearing small. There is no history of trauma to the eye. Sir, slide is not changing, sir.
Yes. Yes, change. Continue.
Yes, sir.
Yeah.
Yes, sir. On past history, there was no similar complaint in the past. No type of diabetes or hypertension, and no history of usage of any other systemic medication. Family history was not relevant. Personal history was normal. There was no history of smoking and alcohol intake. General physical examination, he was moderately built. Pulse rate was 94 beats per minute and BP was 130 by 82 millimeter. On examination, visual acuity in right eye and left eye both is 6/6, and near vision was N6 and color vision was normal. Head posture was normal with visual axis aligned. On examination of the eyeball, right eye ocular movement full and free in all directions, and he was orthophoric in right eye. In left eye, there is protrusion of left eye, that is axial proptosis. There is ocular movement restricted in down gaze, full and free in all other directions. Proptosis inspection was done by Nafziger's method and Worm's eye view. Proptosis measurement in right eye, there was 22 millimeters. It was measured by a ruler, and left eye it is 23 millimeter as compared to 20 millimeter in right eye. And eyelid examination was normal in right eye. There was in left eye there was Enroth sign, that is upper eyelid was swollen, and von Graffe sign, that is lid lag on down gaze, and there was Dalrymple sign, that is retraction of upper eyelid. Eyelashes of both eye were normal. On palpebral aperture, right eye was 28 millimeter horizontally and 8 mm vertically in straight gaze. In left eye, there was 28 mm horizontally and 10 mm vertically in straight gaze. Lacrimal apparatus was normal in both eye. Conjunctiva was normal in right eye, and in left eye, there is congestion present in both medial and lateral aspects of bulbar conjunctiva. Sclera and cornea was normal in both eye. Anterior chamber was optically clear in both eye. Iris, pupil, and lens is normal in both eyes. IOP using Goldman apprentice tonometry was 12 mm Hg in right eye and 14 millimeter of mercury in left eye. IOP in up gauge using Goldman apprentice tonometry was 14 millimeter Hg in right eye and 24 millimeter Hg in left eye. This is the picture of the patient. On fundoscopy with 90D slit lamp examination, media was clear in both eye. Optic disc was normal with optic ratio of 0.3 to 0.3:1 in both eye. Blood vessel AB ratio was maintained. Macula foveal reflex was present, and peripheral fundus was within normal limit. This is the fundus photograph, and so my provisional diagnosis is left eye thyroid associated ophthalmopathy with clinical activity score 3/10. With mild Graves orbitopathy in recent European group on Graves ophthalmopathy class scoring system.
Okay, what is the pathophysiology of the retroorbital swelling? Why does it occur?
Sir, thyroid ophthalmopathy is an immunologic disorder. It affects the orbital fibroblast. So there is increase in orbital fibroblasts. And yes, and increase in adipocyte formation, sir. In an increase in retroorbital fat, leading to increase in retroorbital fat.
Okay.
So it is irrespective of thyroid, you know.
Yes, sir.
So you can get in hypothyroid, you can euthyroid, you can hypothyroid. So why he was complaining that is something in the left eye, right eye? Sorry.
Sir, actually his complaint was his right eye was shrunken. But on examination, we found that right eye was normal and actually left eye was swollen. And on obtaining the history, he told he was a case of hyperthyroidism 6 months back, 1 year back, and he was taking medication for this, and he discontinued the medication due to uncompliance, sir.
It's a case of hyperthyroid is under treatment. Right?
Yes, sir.
Achha, okay. So unilateral hyperthyroidism giving rise to proptosis. Am I right?
Yes, sir. Yes, sir.
So there is any limitation of the ocular movements?
Sir, yes, sir. There was restriction of movement in. Sir, there is a restriction of movement in up gaze, sir.
Up gaze. Okay.
Yes, sir.
Any other investigations you do? Ocular investigations?
Sir, IOP in up gaze should be taken, sir.
Done.
Sir, then proptosis measurement should be done, sir.
Have you done already? There are exams. Any investigations?
Sir, CT orbit and MRI orbit, sir.
Okay, CT orbit, what do you get?
Sir, actually, we have done MRI orbit, sir, and there was inferior rectus, medial rectus, and superior rectus appears bulky on the left side, sir.
Okay. Right.
What is visa classification?
Sir? Sir, visa classification, sir.
You said UGOGO classification, that is more commonly used by Europeans.
Yes, sir. Yes, sir.
But Americans use a classification called visa.
Sir, visa classification, V for vision, sir, I for inflammation, sir, S for sir strabismus. In strabismus, it contains score 6, strabismus score 6, diplopia and restriction of movement. Visa A for appearance, sir.
Okay. All right. Thank you.
Done.
Thank
yes. Good.
Thank you, Dr. Jyoti. I
Yes.
think, Dr. Devi, we are at the end of the question.
Yes.
Hello.
So can we have all the postgraduates and panelists and the judges for a screenshot?
My opinion was that except this last girl, everybody else took longer than 4 minutes. They prepared well. Everybody prepared well, but they did not restrict to time. Otherwise,
So preparing also means making it concise.
right.
Okay.
As we come to the end of the session, I thank everybody, and I think Dr. Sasmita is there. She's there. She's the youngest member in the executive committee, so she'll give the vote of thanks.
You wanted to take photograph?
Yes, Mr. Sharik. Anybody can take a screenshot.
Already done, ma'am.
We are 3 people only. We are 4 people.
Achantina, sir, participants 26 are there.
But where are they? We are only 4, 5 people.
All are video off.
Videos.
They should do
Okay,
video
okay.
on.
Just 1 second. Let me switch on my
Yes.
video.
Everybody is there. Yes.
Everybody, please go on video on mode. Mr. Sharik, we are all there.
President sir, Dr. Khan, where are you?
Bhokwalani.
Audio, video.
I am here only. I am all through here only.
Sir, video on, sir. Video on.
Come with the
Video on, sir.
Come with the video.
Sir was the first to log in.
Asantu.
All the speakers also. Bhumija.
Yes. All.
Jyoti.
Dr. Pragya, Dr. Seva, Asmita, Bhumija. Oh, yes, everybody.
Asmita.
ସୁଚେତା ବହୁତ ପାଠ ପଢିଛି ଏଟା ମୋ ଫୁଟାଇକି ବସିଛି ପୁରା ହେଇଗଲା ସ୍କ୍ରିନଶଟ ହେଇଗଲା ଆଦି ସସ୍ମିତା ତା କାମ କରୁ
ଆସିଗଲେ
ହେଇଗଲା
There's so many screenshots are there.
ହେଇଗଲେ
Sir.
Can I take?
Already taken.
Already taken. Okay. Thanks. Thank you.
Okay, ମୁଁ ଖାଲି ମାର୍କ ଟା କମ୍ପାଇଲ କରି ଫଟୋ ପଠଉଛି
ପଠେଇ ଦେ I'll send.
ଦେବୀକୁ ପଠେଇବି ତ
Yes.
Okay. सरला.
First one is mine.
Yes, sir.
ଏଥର ଆମର MS ପରୀକ୍ଷାରେ ଥାଇରଏଡ ର କ୍ୱେଶ୍ଚନ ଆସିଥିଲା ଫୁଲ କ୍ୱେଶ୍ଚନ
ଆଜ୍ଞା
You are the one of the examiner ଜାଣିଥିବେ ସେତେ correct
ହଁ ଆଜ୍ଞା
So Sasmita can give the vote of thanks.
Good afternoon, everyone. So it has been such an honor to be the part of this wonderful event. On behalf of WS, I would like to extend my heartfelt gratitude to Dr. Mohita Sharma, who is head of WS India, and our esteemed guest, Dr. Aarti Nangia. Thank you, ma'am. Sincere thanks to all the heads of department of all PG teaching institutes in Odisha and judges who handled the event throughout. A wide round of applause and thanks to all the postgraduates and their mentors who made the event a memorable one. Finally, I would like to thank Allergan India Limited for sponsoring the entire series and also thank Mr. Bageshwar Dutt for IT support.
Mr. Sharik is also there.
thanks to the panelists
Mr. Sharik
Yes,
and
sir.
all the panelists.
Yeah.
At the end, not to forget Dr. Aishwarya Das, who has been the pillar of support of this grand event. Thank you.
You can't thank me. WOs can't thank me.
No, you have been doing this.
Sir, all the panelists sir, are the HODs and I am extremely grateful to them, sir. Without their support, this could not have happened.
Thank you